My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're so happy to have you joining us for a conversation today about health spending, moving from theory to action. I'm going to spend just a couple of minutes placing today's conference in context, and then I'll hand it over to Bobby Dubois, who will walk through a little bit about what we're trying to accomplish today. How many of you were at the event we did on this topic last year? Decent number. We thought it was one of our best. We had great attendance, very interesting introduction to the subject of health spending. At Health Affairs, we have a series of papers that appear in most issues of the journal on spending. We have an active set of blog posts looking at health spending, all called Considering Health Spending. We've created a council led by former Senate Majority Leader Bill Frist and National Academy of Medicine Foreign Secretary Peggy Hamburg. They are meeting twice a year to try to make some recommendations in this area. They'll actually be meeting for their second meeting next week in Chicago. And for those of you who were at the event last year, I won't try to summarize the day, but I think it's worth thinking about what some of the lead takeaways were there, which led into our structure of the day today. If I had to summarize, and this is really not doing justice to a robust set of conversations, I'd say three things came out of the conversation we had last year. One is that there are two really very different views of the problem of health spending. One is a system-wide view, share of GDP, burden on government's ability to pay for the programs that provide access to health care. But there's also the family individual problem, which is an affordability problem of individual services, drugs, access to care, high deductibles and co-payments, high premiums coming out of paychecks. And they're related, but they are actually different ways of thinking about the problem. And if we're going to have a conversation about spending, we have to talk about both. The second thing that clearly came out of last year, and it shouldn't be a surprise to anyone, there's no single culprit here. This is a sixth of the economy. It's always easy to find someone else who's driving up cost, but that doesn't mean you aren't doing it in your own sector as well. And we need to make sure we don't say, oh, let's move the focus over there. The focus needs to be system-wide. And that leads to the third element, which is that there's no single approach which will address these two problems of high spending, because there's no single problem that we're trying to address. And so, as I say, Bobby will walk through more about the structure of the day, but that's just some of the thinking that went into how we try to move from the more theoretical side to an action-oriented side. It takes a lot of effort to put this together. It takes financial support to do this, and I want to acknowledge the National Pharmaceutical Council, which is the lead partner with us and is working with us on those other elements that I described around considering health spending. We also have the Alliance of Community Health Plans, the American Cancer Society, the Blue Cross Blue Shield Association, and the Council for Affordable Health Coverage, helping make today's event possible. And I want to acknowledge their support for bringing us all together here. With that stage setting, let me turn to my partner and colleague, Bobby Dubois, Chief Science Officer, EVP of the National Pharmaceutical Council, worked with us on building this program, also a member of the Health Affairs Editorial Board, and he'll tell you a little bit more about what to expect for today. Here's Bobby.
Good morning, everyone. My job is to sort of explain what's the day going to look like. Of course, lunch will be the centerpiece. No alcohol served, but that's all right. Just so everybody is aware, who here represents the payer community? Okay, some. Provider community. Now, it's not mutually exclusive. You can raise your hand multiple times as this goes on. The patient community, government, advocacy working with the government, academia, employers. Any other great categories I'm missing? IT. Industry broadly, pharma device. Okay, well, it's a rather balanced audience, which is what we were hoping to have. So, today's activities, we're going to begin with Dr. Reed Tuckson, who will set the stage for us on why we actually have to do something, really do something. And his many years of perspective, and I'll walk through that in a little bit, will sort of bring that to light. We will have, or not, there we go. We're going to have 3 panels, and that's really the key parts of the day. We'll have 2 keynote speakers and 3 panels. And the panels actually, some thought went into these panels, not surprisingly. As Alan said, last year we really wrestled with how big a problem do we have, where is it coming from? But we really didn't get into how do you solve the problem. Now, I'm a pretty simplistic guy. I put things in buckets, which may be overly simplistic. But when I think about how do we handle our spending problems, there's a bottom-up approach, which I learned just recently is not a bottoms-up approach. A bottoms-up approach is what happens when you drink beer. It is properly referred to as a bottom-up approach. So the bottom-up approach says we have services. Are they needed or not? How do you decide? Who should give those services, and what should you pay for them? That's a bottom-up approach. There's stuff that isn't absolutely necessary, maybe harmful. What do we do about it? Okay, that's the bottom-up approach. That's the choosing wisely campaigns. That's the kinds of things we hear a lot about. Okay? The top-down approach, again, this is simplistic, is that you set something up here. It may be a global budget like Massachusetts. It may be a capitation rate through a Medicare Advantage. It may be a bundled payment scheme. We're not telling you what services to give, but we're going to set constraints, and hopefully that will drive its way down into better allocation of resources, okay? So there's a bottom-up approach, the top-down approach. We're going to have panels on each one of those, folks who really are steeped in this. So the first one will have a number of folks who either have experience in evaluating these kinds of decisions, implementing these types of decisions on behalf of payers and providers and patients and others. So that's one panel. We have a slightly dysfunctional, I'm probably doing nothing and somebody else is actually moving the slides because this is not working. Next slide, please. Well, that's much easier. Then we will have Robin Gelburd from FAIR and talk about data. Now, often these data discussions can be like, oh yeah, another data discussion. But what her group is doing is not only using data to find where the problems are, they're actually using the data to drive decision making. So that will be a very good chance to see, again, another approach. Next slide. So the second panel will be the top-down approach. And we're going to take a deep dive into what's going on in North Carolina, both the blues from the payer standpoint and the state government. And we're really going to talk about what is that top-down approach. They have their way of going about it, and we can expand from there as needed. Okay, the last panel, and maybe that would be the next slide, or potentially the last slide. Thank you. Is perhaps the most important in some respects, which is where do we go from here? And these are the fundamental questions. How much do we actually want to spend? Who is supposed to decide between the top-down and the bottom-up approach? Who's supposed to say no if we can't have everything we want? And to me, the key word of how I look at it is trade-offs. What are the trade-offs that need to be made? Who's supposed to decide on them? Who's supposed to make them? So at the end of the day, which is the end of my slide presentation, I'm hoping 3 things will come out of this. I know there will be greater awareness, because I know the speakers, they're great. You will be more aware. I know they're great speakers, so I know you will have greater understanding. What I don't know, but my plea is, this isn't another day to blabber. My hope is that there will be a greater willingness to act. And if that is the case, I will be very happy. And I'm sure you want to make me very happy and Alan very happy. So a greater willingness to act is what I hope will come out of this. Now, with that, let me introduce our keynote speaker number 1. Dr. Reed Tuckson will be exploring with us why we have a problem and why we cannot keep kicking the can down the road. Reed has a perspective from all aspects of healthcare. So when he speaks, some of us are old enough, the E.F. Hutton commercials. You know, when E.F. Hutton says, at the restaurant and everybody gets quiet and they lean in. So I think that's what we're going to get from our keynote speaker. He began he's a physician, trained, I have all of his stuff right here. He's a graduate of Howard, went to Georgetown for his medical school, did internal medicine residency and fellowship, University of Pennsylvania. He began in the public health world with being the DC Commissioner of Health. He worked over the course of his career in the provider world. He was a senior individual at the AMA. He was the chief medical person at United Healthcare, so the payer experience. He came from the research world and the academic world. He's worked with the industry, pharmaceuticals, and the like. Has really that broad perspective. And so I think when he can speak from all of these vantage points and then summarize why, in fact, time is not now, time was yesterday, to really do something. So please join me in welcoming Dr. Reed Tuckson.
Thank you so much. It is true that I've had a great privilege in my career to, I could have raised my hand for every single one of the categories, which really does inform my perspective. And I want to emphasize as I go through this very quickly with you that I don't see the world as having demons. I don't demonize any of the sectors because I have met some of the most wonderful, principled, idealistic, moral people in every sector that we have worked in. I don't know how many of you, but every meeting that I have ever gone to, it seems like for the last 10 years, we have had somebody say, healthcare's percent of GDP is going to be such and such, and it is absolutely unsustainable. The sky is falling, the end is near. And yet, every year, we kick the can down the road just another bit more. And I believe that we just feel like this can go on forever. Clearly, I think we've hit the wall. And I think anybody that is rational believes that this really is the moment where there is no going further. This is as far as we can go. We are there yet. Our industry considers itself special. We think that we deserve a certain kind of autonomy, mainly because we are grounded in the ethic of the Hippocratic Oath from the physicians and health professional side. And then that, of course, transcends itself into hospitals and every other part of what we do. We have a moral grounding to the work that we do. We take that seriously, or we used to. This was very key to the essence of what it is that we are. And now the focus much more of everything that I hear and see everywhere I go is on the money, and the Hippocratic Oath part starts to get diminished every single day. I went back in preparing for this invitation to talk about this, and I went back to one of the true norths of our work in the world, and that's the World Health Organization's sense of what is health. And we always knew, and we love to celebrate, that it's not the absence of disease, but the mental, spiritual, and physical well-being. But when I went back and looked at the original, it says things like social well-being, and it says that people have a right to care, and without distinction to race, religion, political belief, or economic condition. This is a true north that informs not only the work that we are doing in the nation, but also this is a true north for the work of the world, for being a human being in a place called the world. When you look back at us from outside of the United States, and all of you are so sophisticated and you understand everything that is on that slide in terms of what do we look like, it is surprising about what we do not have. But what's curious and important for me on this is that how complicated and fragmented, but it's also the absence of a broad consensus on the role of government and a broad absence of a broad consensus on what are we trying to achieve. Governance in this industry is unclear. And what is also key, and the absolute word is accountability. There is no specific accountability for what we do across the many different components of our industry. And at the end of the day, every sector is primarily today focused on the bottom line. This is not meant for you to memorize. It is meant to show just the extraordinary amount of tools in the toolbox. I have seen every one of these, and I'm watching these, whether it's bed day management, medical necessity review, whether it is comparative effectiveness research, high deductible plans, risk-based incentive, addressing social determinants, populate, telemedicine. Every one of those are great tools. We've been playing the tools in the toolbox for a really long time. And I guess we'll invent a few more along the way. But we got a lot of tools. And those tools have led to what? Diddly squat. Diddly squat. The escalation, we just accept as a norm increasing. And then, in terms of how much we are going to be spending on medical cost trends. But now, even at the levels of when it was flat, it was still too much. And now, after all the tools, everything that we're doing, still headed north. The most important decision that any American is going to make now in their life is going to be how much they health care. People make every choice about who and what they are, where they go to work, what state they're going to live in. They're making those decisions. When you have the choice to make a decision about your life, it's going to be how much you're going to spend, and it will be amount of what is basically a car. And it is not only the employer component, but of course how much workers are paying in premiums and how much they're paying out of pocket. We know these slides well. I'm just rehearsing for you the fundamentals. Employer premiums have risen, and so have employee contributions. We see the size and the magnitude of that. We know that worker payments for employer coverage are growing faster than their median income. Anybody in this room believe that wages are about to go up enough to compensate for that? And the answer is, of course, hell no. It ain't going to happen. It's not going to happen. It can't happen. We know how much the average deductibles are and that they're outpacing that income, extraordinary level. We know that premium and deductible costs amounted to nearly 12% of median income in 2017. That's the combined premium and deductible. And now we know that more than 1/3 of individuals and families didn't have enough saved to pay for their deductible. And that's just, the 1/3 is just for the lowest rung on the chart. And you can see how much it is for higher amounts of as you go up to the higher levels of deductibles. People have not saved enough for that. 1/3 of adults struggle to pay their bills. The Commonwealth people who are brilliant to ask the question, if you were to experience an unexpected medical event that left you with a bill of $1,000, would you have the money to pay for it? Look at the number of people who could not answer that question yes. This is amazing, and you think about all the TV shows, and we think about, one of the challenges that we have in healthcare is that we do pretty well, and the people we hang with do pretty well. You get a sense in America that everybody kind of lives like we live. Like we live good, they live good, everybody's buying a new TV, Walmart is filled. Christmas time when we're getting ready to have Thanksgiving with Black Thursday, whatever they call it, people will be lined up. Things look great in America. Look underneath the cover and they suck. I'll show you how bad they suck. Look at the number of people that are living paycheck to paycheck. 58% of Americans have less than $1,000 in savings. More than a third of U.S. consumers live paycheck to paycheck. 60% of millennials don't have enough to cover a $1,000 emergency, the question that Commonwealth asked. The typical American household has an average of $863 in an account or a bank account. What that really means is that when you look at it from retirement, and those of you that do Medicare work, you understand this very well. The emptiness of the average American retirement account is so clear. 21% of Americans have no retirement savings. An additional 10% have less than $5,000. One third of baby boomers have $25,000 set aside. And I'm not going to have time to put the concomitant slide, which is the increase in how much out-of-pockets are being paid by those over 65. Think about what that means to people who are over 65, who have got to figure out how to live the rest of their lives and still be able to have health care when they are really, really going to need it. Consequence, a whole bunch of people are uninsured. They have insurance, they're underinsured, which means that they have to make decisions every day about what they will or will not do. They will push back on their medication because they've got to put food on the table. These are horrible choices that real people make every single day of their lives. And of course, the number of people now that are uninsured. After we thought we had this thing won, we thought we had done it, all the effort. How could it be possible that in America, a nation of this wealth and wonderfulness, how in the hell could we have climbed up to the top of the hill and then fallen back down again? And that's not a political statement, that's a moral outrage statement. Medical debt is really now what is scary. Over more than 1/4 of consumers with a credit report have at least one debt in collection by third-party collectors. More than 3/4 have third-party collections for credit accounts on your credit report. 58% of those are for medical debt. And where it's really bad is now we are seeing providers having to sue patients to be able to get their money. 20% of U.S. consumers had medical debt in collections in 2014. It's increasing now, of course, with direct patient billing, rising insurance deductibles, out-of-network. Some hospitals are now adopting really aggressive strategies for collecting unpaid bills, and where that's particularly a problem is in rural America. And now we are seeing not only and by the way, one thing we have got to talk more about in this country is the rural hospitals. I mean, this is really, really a neglected area. It's still flying under the radar. But the number of hospitals that are closing, but the deal is that like in this place in rural Missouri, you've got to have them going out and taking their people to court to get their unpaid bills. What the issue is emergency medical care has become a standoff between hospitals and patients who are both going broke. And that's the real issue. No villains here. Adults with medical bill or debt problems have serious financial problems outside of just their health care. What this means is that we've got 3% using their savings, 43% receiving lower credit rating, racking up debt on credit cards, delaying education or career plans, and unable to pay basic necessities like food, water, or rent. And so what you get are a whole lot of people who are living in despair. And we have seen this sea of despair not only affecting this, but rolling over into prevention. Because those now who are seeing no concept of the possibility of a meaningful future are now taking and doing behaviors that are inconsistent with survival. We in the African American community have lived this forever. We always knew what it meant to have no concept of the possibility of a meaningful future. So therefore, why do I worry about tobacco smoking or alcohol or any of the stuff we were doing? Because there wasn't going to be any happy outcome any damn way, so you might as well have a moment of fun. And all of a sudden, we have the opioid crisis, and you see people talking about this, and how many meetings have I been to that says even good families are having this problem, please. Even good families. Well, now everybody is in the mix today, and that sea of despair is leading us to obesity is just one example, We know the economics of obesity. We know what it's going to cost the system. I could put the same slides up for cardiovascular disease leading on, and I could put the slide up about diabetes, which directly comes out of the obesity epidemic. And now we understand that diabetes drugs are the 6 of the top 20 prescription classes, 214 million prescriptions, spending $5,000. But this is the deal. Even if you have insurance, look at the numbers of people who are doing all kinds of things to be able to find some kind of way of paying for their diabetic medication. You know the outcome of this story in terms of, for the first time 2 years ago, we saw the cardiovascular death rate, which had always been as a given assumption going down, is now what? Going up. And guess what? That means a whole bunch of more people need to be coming back into our hospitals and our medical care system to pay for preventable illness when we couldn't afford the burden of illness that we have today. What do you think is going to happen? This is a train wreck on our watch. And that's the key word for me, on our watch. Where do we spend our money? This is one of the great tragedies of this nation. It used to be, back in 1980, we spent 11% of GDP on social programs. The European Union spent 15. The gap started to widen really big in 2011 when it went from 16 to 22. Social underfunding has more long-term implications than underinvestment in medical care. The most efficient way to improve population health is to focus on those at the bottom. What is our public policy today? We're going to take away more of these from the people that need it the most. Guess what's going to happen? They're going to get sick as hell. Guess where they're going to wind up going to the hospital? Inner city, rural. We already can't pay it. It's a train wreck happening while we are sitting here. And Joe Newhouse got it right. Medical care is one of the less important determinants of life expectancy. Socioeconomic status and other social factors exert greater influences on longevity. Where does the money go? United Health Group put some stuff together. I think it's pretty consistent across most of the insurers. 80 cents more of the insurance premium, it comes on medical spending. It's on taking care of people. However, prescription drugs and outpatient services are driving premium increases. And then, of course, taxes on the insurance industry is very important and very large. Almost 6 cents of the premium is just in taxes alone. Hospital expenditure. I love hospitals. I was on the board of LifePoint Health. I love those people, for profit. 30 states, all rural and small town America. I love the hospital people. I mean, there are no villains here. I love everybody. But look at the escalation in hospital prices. This is simply impossible. Hospital price increases over inpatient service will cost consumers, employees $250 billion over the next decade. Real issues. Hospital consolidation as a result of what's going on in terms of the change. What do you think this is all about? We know what the mega mergers are about. This is pushing even harder to be able to have the kind of negotiating power to drive up and get more reimbursement. I'm not saying they don't. Nobody's evil. $11.3 billion in total transacted revenue in the recent quarter, which is extraordinary. But also, physician compensation. Look at what's happening now in physicians getting paid without any concomitant increase in productivity. So this is a significant slide. And median compensation increased by 4.91% from 0.76 in 2017. Productivity was flat. If you look at it from the specialist point of view, same story. Same story from the specialist point of view. Everybody wants to get their money. Mrs. Jones on 5th and Vine ain't getting diddly squat. And now private equity comes in. Provider deals in U.S. investment, 84 transactions worth $23.2 billion of the 29.6 nationally. That $63 billion is national and international. But of just the U.S. side, $29.6 billion. Behavioral, retail health, physician groups, and home care are getting the most interest. But autism care and other specialty segments hold the promise of returns. There's money to be made, people think, in taking care of people with autism. Now, Lord knows how many of us have children or family members or neighbors with autism. We want them to get the services that they need. But there is a rapacious opportunity that some people see in being able to go after that as a market. They're going after consumer-friendly alternative care models, looking to build scale in fragmented categories. Their goal, achieve high returns at least around 2.5 times over a relatively short period of time. Private equity, again, looks like this, eyeing 400% return. Attracted to specialties that promise rich revenue from ambulatory surgery centers, lab imaging, and other ancillary. Dermatology, 200 practices have been acquired by private equity in the last 6 years. What do you think the point of those investments are? They're looking ultimately to develop market leverage. What? To get big enough in any area to get payers to treat them with respect. This is hardball negotiating to drive up unit prices. And at the end of the day, just to make sure that we don't leave out some of the other sectors, but the device manufacturers, the range in prices for electrocardiograms, MRI, ultrasound, CT, extraordinary range that's unexplainable in terms of how those costs are generated. And then, of course, our employers concerned about million-dollar treatments. This is such a common issue in the public debate that I won't even spend any time on it. You know this stuff, except for this line. 46% of respondents for the large employers would now consider a role for government. And that is an extremely telling statement to be understood. So where do we go from here? Where do we put our dollars? There's going to be a panel, and people will talk about that. Let me just sort of say a couple things in closing. Number one is we put our money in the wrong places. And we are such an outlier, and we get so little for it. The American people understand this. And the more they understand it, it will fuel the next stage of what happens, I think, going forward. Do we put our money in prevention or into life care? I'm on the board of startup pharmacy companies that are trying to develop very important drugs for chemotherapy. How long will our drug extend life? We think it'll extend it quite good. But what if you could say, I'm going to have a new drug that will extend life for 3 months? That's important for Mrs. Jones. She wants to be able to go to her son's graduation or attend her daughter's wedding. But 3 months for $1 million when we put nothing in prevention. How much do we put in social support? How much do we put into clinical care? Those are important conversations. No, we just push the balloon. We just squeeze it. We don't make any really hard choices. No sector is actually willing, and of course they will never be self-sacrificing. That's key. No, none of them will. Competition or regulation. That's what's standing in front of us. Market forces are not working. Do we have time to allow the market forces that we are working on to catch up and do what they're supposed to do? Is it time for market caps? Employers are pursuing market-based solutions, but if they don't work, employers may wind up pushing for health care to be regulated like a public utility. And then you have the recession that's getting ready to hit them. What do you think is going to happen in a minute when the recession hits? The employers are going to go ape crazy. Because times are good now. They can pay bills a little bit, but they sure won't be able to pay it when we get to the recession in a minute. The pressure is going to be intense. Thank God states are getting involved, and much of the action will happen at the state level. This is an important article in Health Affairs by Murray Delbanco et al. And we will see things. I think that the conversation you're going to have with North Carolina is a very important example that gives many of us hope and excitement, and good forum. But this is the one that I think I'll end on, in terms of what it interests me. Was this foolishness, public relations, or were they serious? When the Business Roundtable came forward and said, you know what, it's time to have a different conversation about what our industries do. Maybe shareholder return is not anymore number one. I've served on a bunch of private sector boards, and every meeting we go to, the first thing you say is shareholder value, shareholder value, shareholder value, shareholder value. They're saying, hold on a minute. There's something different today than before. When will there be a meeting of the CEOs of hospital, pharmacy, insurance, employers, every device, every sector that says, hold it, folks, this has got to change. And if we don't come together and do what they have done, heaven help us, we deserve whatever happens else to us. The people's voice is not sufficient in the marketplace. There is no way that that gap between affordability and wages will ever be closed. That misery and concern by these people sitting around the dining room table on Sunday afternoon, there is no hope for them. If leave us alone is the industry mantra, there is no choice but political solutions. And if political solutions are going to be the answer, it will be like surgery with a sledgehammer. It will be unpleasant, unpretty, unfocused, and very broad and ugly. The lessons of Pecori ought to tell us something. Pecori loved those people. They still have to tiptoe around the notion of, we're going to look at cost. The Congress, you can't really look at that. Death panels, So what will a political solution really look like? They're not even prepared to deal with refunding Pecori like it should be. And we love them. They're the best thing in the universe. We love Pecori. They should get more money than they ever got before with no constraints. So a political solution, it's the first time I've ever put it on a slide. I have never believed that I would get to a place where I would put the word rationing on a slide. Never thought I would ever say it. Everybody cannot have everything all the time. That includes patients, that includes hospitals, that includes pharmacy, that includes You can't have it. By the way, there already is rationing. It's not like it ain't going on. We just don't want to say it because this is what? America. We don't do that here. We're doing it all the time. I conclude. This is a very difficult conversation to have. I love everybody in every sector. In the final analysis, there is no one who can figure this out but us. We are all that they have. But the question becomes, have we earned the right to autonomy? Have we earned the right to be treated as special? I will say this as my last comment to you. I love being a doc. I love being a health professional. I love every part of the sector that I've ever been in. The answer to that question is we have not earned the right to autonomy. We are not earning the right to be treated as special. And we will suffer the consequences politically, inevitably, in short order, for our failure to be able to move rapidly enough and stop this nasal gazing and self-congratulatory behavior that we have with the latest scheme and dream to be able to whittle away some little teeny piece while the Titanic is sinking. Ladies and gentlemen, this is our time. It is on our watch, and we are not up to the challenge. Thank you all very much. Apparently, there's just enough time for a couple of questions, which I tried to leave as little as possible. For somebody will feel that I have gored someone's ox, and I'm going straight to the airport after this is over. My man.
Okay, I'll do it like this. My name is Mark Berg. Hi, Reed. Thanks for a fantastic talk.
Oh, here we go. We got this right here.
It's probably a little bit more comfortable. Yeah.
It was nice getting to know you.
This thing's still on? Yeah. All right. Mark Berg, two slides that together were, I think, really pushing down the point we're trying to make, right? If you look at what's happening to the hospitals right now, if you look at that increase in price, right? At the same time, you see a decrease in utilization, right? And you then think about that moment of the car hitting the wall. What you're seeing now over the last 2 years very clearly is that utilization is actually decreasing because of, well, we all know why, a lot of different things happening at the same time. And hospitals are managing to keep their head above water, if barely, by jacking up those prices, right? That's, if there's any moment in time where it's going to be essential what's going to happen there, it's now. Because if that is going to be in one way or whatever allowed to happen, right, by whatever mechanism, I don't see how we're ever going to get out of this. Because obviously, I think we all realize that one big answer here is that the hospital inpatient, bricks and mortar was going to have to be restructured. Are you hopeful? Or are you pessimistic?
Great question. First of all, I used to make my living, I used to be a jazz drummer, and I used to love John Coltrane. And John Coltrane was terrific in the sense that it was very advanced stuff, and he never played down to the audience. He always said the audience will play up to, they'll get it if I just know what I'm doing. I don't take the American people as being dumb, and I don't take our industries as being incapable. I also know that I'm fired up for solutions. I am not a pessimistic person by any means, and I take problems and I tend to be like y'all. You know, we didn't get to where we are. That just get beaten down by the gravity of it. However, having said that, the answer to your question is I am very pessimistic because I believe this. There is no way until there is even more of a crisis. And if the Democrats get in and they start talking about Medicare for all and all that kind of foolishness, and you leave out the practicality of Medicare for all, leave out all, I can't work because of blah, 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 blah. Yeah, we all know that. What they're saying is something different. And they're saying this, the American people are fed up. It can't go anymore. So my point is that I think until we get to that place, I still worry that we're going to kick the can down another road. I don't think that summit call that I looked for, where everybody gets together and when they decide that we're going to avoid that, I don't think it'll ever happen. I think people are going to milk this damn thing until they can't milk it anymore, and I am pessimistic. And having said that, the baby died and the doctor went home? No. I think we're going to re-energize our efforts going forward. So I am pessimistic, but I ain't defeated.
Lou Diamond. So, Reed, thank you very much. So, when Bobby took the inventory, if you will, of the folks in this room across a wide array of professions, they were mostly focused on something called the delivery system. And we know from data that the delivery system only impacts on patient outcomes a minuscule amount, that the major driver to cost and outcomes is outside of the delivery system. It's personal behavior, genetics, and the community and related behaviors. Could you speak to how do we get that part of the community to the table? Because those of us who've spent most of our time, and you started your career in the public health system, in the delivery system, we keep speaking to ourselves, and we only now beginning to bring the rest of the community and the public.
I think one of the thanks, Lou, by the way. He taught me medicine when I was at DC General. So I wish you'd done a better job. I'm sorry. I didn't do well enough. One of the things that we have to celebrate, and I think we can be excited about, is this idea intellectually that value-based reimbursement that rewards clinicians and hospitals for the outcomes of care suddenly does transform or create an impetus that we start now looking upstream. They identify patients early so that we keep them from tipping, where now all of a sudden, if they tip into being sick, it costs me money. So now I need to care about upstream. And now we got this wonderful movement around population health and social determinants of disease, and lots of money legitimately being put into that. I think that is really, really, really exciting. What is weird about it is public health is still not part of that conversation. I keep trying everywhere I go to have the public health department now completely accountable. Which, by the way, I love public health, but come on. They are accountable for very little. There's no consequences for failure. They don't have to be organizing their systems to partner with ACOs in a meaningful way to take out risk in a way that is predictable. So, but I still think it's an opportunity to pull all that together. So, Lou, I think that that's really where the excitement has to be, that we will eventually see movement in that area. That being said, when's the last time we as an industry, and I will end with this since I see the boss, when have you ever seen our industry collectively going to the halls of Congress, and instead of advocating for our little puzzle, our little piece that said when they cut those benefits down to the food for poor people, and when they started cutting down those elements for poor people to be able to survive, when did we ever go down there and fight for that? We never did, because we really don't believe it in our soul. Thanks.
As always, a tough act to follow, but follow we must. So, panel, please come on up. Well, since I did such a great job with moving the slides last time, they've now taken away the clicker. Oh, is this the new clicker or is this the old clicker? Well, it's working really as well as the, oh, wait a second, it is working. Wonderful, thank you. Okay, so on to the first panel. So now we've been charged with figuring out what can be done. And so this first panel is going to explore decisions at the point of purchase or the bottom-up approach. Now, in essence, that's about the fact that low-value care, services that are not needed or provided in an efficient way, we might not want to do them. Now, this is not new. It's been around for 40 years. Back at RAND, they identified that 1/3 of all healthcare was unnecessary 30, 40 years ago. Now we're about the same place as we used to be. Choosing Wisely, a great campaign, absolutely has raised awareness and has really only chipped away at the margins. So low-value care has been stubbornly persistent. Now, it's not for lack of tools. I loved Reed's slide of the myriad of things in our toolbox. Now, I've only chosen a few, and these are the ones that can help us with low-value care. On the left, there are practice guidelines that are on our iPhones that doctors can look at and say, is this angioplasty needed? Is this type of chemotherapy proper at this point in time? In the oncology space, NCCN has very detailed and elaborate practice guidelines for clinicians to follow. Prior authorization is a technique by payers to say, let's look at an individual drug, an individual device, an individual surgery, and see whether it's absolutely necessary. And on the cost effectiveness side, organizations like ICER have sprung up to say, what is the value of this intervention? So there's no lack of approaches. Oops. But there are key questions we need to address, and I'm hoping our panel will do just that. And so these are some of them. When does it make sense to examine individual services? There's a myriad of them. Can you look at all of them before they're done? Perhaps yes, perhaps no. What are the pros and cons of that approach? Who decides? Who decides what is a service that should be done, should be paid for? Who doesn't? Since we haven't succeeded thus far very well, can we? And are we going to be left with what the UK has, a NICE that evaluates services and decide what gets paid for and what does not? And so those are some of the questions we need to address. And to answer those wonderful questions, I get to sit back and listen and hear, as you will, from our four speakers. So from your right to left, we have Dr. Otis Brawley. He is a global leader in all aspects of oncology care and population health related to that. He's an oncologist. He is currently the Johns Hopkins University Bloomberg Distinguished Professor. He was the Chief Medical Officer of the American Cancer Society, and he understands decision-making at the point of the patient and doctor interaction, as well as all different levels above that and how to drive health. So I think his perspective will help us from that standpoint. Next, we have Dan Ollendorf. Dan is the Director of Value Measurement and Global Health Initiatives at the Center for Evaluation of Value and Risk in Health at Tufts. He has expertise in the tools that evaluate individual services. He was the Chief Science Officer at ICER, the Institute for Clinical and Economic Review, putting together those types of cost-effectiveness assessments, and will give us a perspective on what can be done, what can't be done, and more importantly, what should be done. Then we have Dr. Surya Singh, who is president of Singh Healthcare Advisors. Before that, he was the corporate VP and Chief Medical Officer for Specialty at CVS Health. While he was there, he was in charge of policy making on many different fronts. The one very relevant to what we're doing today is CVS announced some months ago, actually probably a year ago now, a formulary that would be limited to only drugs that were cost effective below $100,000 cost per quality. How was it set up? Why was it set up? What's the receptivity? Do we expect to see this grow moving forward? So he has a very important understanding of the payer and patient interactions and how that all works. And then finally, we have Elizabeth Mitchell, who's the president and CEO of the Pacific Business Group on Health. $100 billion of healthcare purchases underneath that umbrella for 15 million employees. And they have a particular focus on all the issues we're talking about today with affordability and how creative new approaches can be done and need to be done. Prior to that, she was in the payer world at Blue Shield. She's been in the world of quality improvement, integrated delivery systems, and was in the Maine state legislature. So what I have asked the group to do is to take a few minutes and explain where they're coming from, their perspective. And not surprisingly, I have some questions to ask of them, and then we welcome you to begin to think about the questions you want to bring to the group. So Otis, do you want to begin the dialogue?
Yeah, thank you. Thank you for the invitation to be here, and it's wonderful actually to follow Reed Tuckson. Dr. Tuckson's comments are extraordinary. I will point out that I do think social responsibility is shareholder value in the long term, and especially as we get into more and more financial trouble, I think shareholder or social responsibility will become more important. I'm going to talk a great deal about gluttony and the overconsumption of healthcare and how that can actually be harmful. But I also want to point out, Warren Buffett said, cost is what you pay and value is what you get. And I think that the value that what we're getting is pretty sparse or pretty low in many instances. One of the problems I think is that many of us in our thoughts have turned too many things into illness that we want to treat, and indeed corporations have made some illnesses just so that they can treat them, and we need to start stressing prevention of disease. And prevention of disease is not taking herbs and vitamins and spreading misinformation about herbs and vitamins preventing disease, by the way. When I talk about gluttony of consumption, let me give you two examples of how the consumer very frequently overconsumes and can actually hurt themselves. First, let me talk about the PET CT scanner. It's a wonderful imaging modality that came to us in the late 1990s and really became very common in the early 2000s. PET CT scanning is commonly done in staging, for example, of breast cancer. And I personally have used the PET CT scanner to initially stage a breast cancer, see the status of disease. Now, choosing wisely noted that that is the appropriate use of the PET scanner in breast cancer. One of the problems that we have is many people who, after treatment for breast cancer, are under surveillance to look for recurrence of disease. Actually, if you're taking the internal medicine boards and the medical oncology boards, or you're looking at the people who write Choosing Wisely, proper surveillance is talk to the patient, talk about symptoms, do a physical exam, do some blood tests, do a mammogram, but it is not to do a PET CT. It is very common now in American medicine that women after treatment for breast cancer get a PET CT scan sometimes every 6 months. Oftentimes once, but sometimes every 6 months or every year, just looking to see if the disease has come back. Now, this actually creates increased anxiety. It can create false alarms. It can create unnecessary procedures. It's added radiation exposure, which in itself can cause leukemia, and it just doesn't work. But people do it. Doctors prescribe it. Why do doctors prescribe it? Because they're afraid that patients will not come back to them and will go take their business elsewhere. Next thing in my brief time I want to talk about is proton beam therapy for prostate cancer. These are $300 million machines. They're popping up all over the United States. There are about 80 in the world, 27 of them in the US. Venture capitalists are investing in these things. There are no clinical studies that tell us that proton beam therapy is better for prostate cancer than conventional IMRT. The reimbursement for conventional IMRT is about $18,000. For proton beam, it's between 40 and 80. I still don't understand. Medicare is reimbursing proton machines at a higher rate because they are underutilized. We have no science to show that it is better than IMRT for the patient. We have economics to show it is better for the provider, but none to show it's better for the patient. It is being advertised as being the new therapy. They can't say it's better. There's theory that it might be better. They have suppressed doing the randomized trials to actually see if it is better. This is medical gluttony. We've got patients who are insisting upon it, suing their insurances to get it, and you've got investor community providing it. By the way, about a third of all proton beam machines in the United States are currently in bankruptcy or some type of economic distress. By the way, there is appropriate use of proton therapy for brain tumors at the base of the skull, tumors in the eye, for certain pediatric tumors. The most common use in the United States is for prostate cancer. Second is for adult breast cancer. Third is for lung cancer. By the way, in lung cancer, they're the only randomized study in proton therapy to see if proton versus IMRT that has been done shows that IMRT is equivalent to proton therapy, but we still use it. It is an example of irrational gluttony. By the way, last thing I will note, Reed talked about rationing. I like to talk about rational. Rational use of healthcare is something that we simply do not do in this country, as we're gluttonous and overconsume, frequently in a very unscientific way.
On that positive note,
So the clicker's over here.
clicker is, yes, should be.
Okay. There we go. So thanks, and thanks, Otis, for your comments as well. It's actually reminding me of my first ever review when I was with ICER, when ICER was just Steve Pearson and me, in fact, proton beam therapy. And that was 12 years ago. Obviously, very little has changed over those 12 years. So so this slide is labeled, "We're not there yet." Here's a cheeky little cartoon talking about cost pervading every possible conversation between a patient and their doctor. Maybe that is the future, but maybe that's the present in some situation as well. So obviously, costs are a concern, and they're coming down to the level of individual patients and families, and that is why we're all here. And one of the things that has happened, however, is that value is part of the conversation. So thanks to Boston Health Economics for lending me this slide. This is kind of an ICER headline cloud. So the conversation around whether new therapies, whether new innovations in medicine, drugs, devices are worth the money is now happening more than it has before. So if we think about cost effectiveness analysis, or CEA, budget impact analysis, and how routine this information is being supplied as part of that conversation, really historically, cost effectiveness analysis was largely an academic exercise in this country, right? So academic researchers would produce this information. Sometimes industry, and oftentimes this would fall on deaf ears, would use this kind of analysis to try to support a value argument for their products. But now they're really not terms of art anymore. They're actually being used to support decision making. So a recent survey that was conducted by Icon PLC of payers primarily and self-insured employers around their use of ICER reports suggested that they're used pretty frequently for pharmacy and therapeutics processes, for price negotiations. So this kind of information is now becoming part of the conversation. But there's still inconsistent use of this information and decisions made based on this information in practice and policy. So when I was at ICER, one of the largest reviews we did was for immunomodulatory therapies for psoriasis. At that time, there was a suggestion that most of these therapies were actually pretty cost effective, but a lot of payers had entrenched prior authorization and step therapy protocols in place. And the conclusion of the ICER report that these were all cost effective and some of those restrictions should be taken off, again, really nothing changed based on that report. And one of the things that may have led to is sort of the shining of a light on some of the challenges and the deficiencies in the rebate system that we currently have, that there were entrenched actors who had primary position in some of these step therapy protocols, not necessarily tied in any way, shape, or form to clinical value or cost effectiveness. In other situations where there is a price issue, where price may not be aligned with value in some circumstances, some therapies for rare disease, oncology, et cetera, again, things haven't really changed, and restrictions that maybe should be put in place to try to improve affordability have not been. So inconsistent use. So focus for economic evaluation, and a lot of these opinions are largely mine, but we'll certainly talk about it. So health technology assessment in the US really does not fill a gatekeeper role like NICE in the UK does, other high-income countries, highly developed countries as well. So it's not as though you have to cross this hurdle in the US to get market access. Because of that, I think cost-effectiveness analysis and budget impact analysis will grow in importance, but really only as inputs into a larger gestalt. And many would argue that's as it should be. There are lots of contextual issues and concerns that need to play into decision-making in addition to this information. So I think the focus then, if without a gatekeeper mandate, should really be on those areas where there is high impact to be concerned about. So if there's a breakthrough therapy, a real change in the clinical paradigm, and a need to understand how valuable that change is, that's one area. If there's a great unmet need, a big public health burden in another area, that's also important. And yes, if a large population is affected and the potential for budget explosion is there, that's another area. So this sort of bottom-up approach, if these kinds of tools are going to be used, they should be focused on areas like this. So from an analytics standpoint, let's talk about some pluses and minuses for a second. I know I'm almost out of time here. The benefits of cost-effectiveness analysis, the ability to assess health gain and costs at the margin. So adding something new, how does this change incrementally? Can identify areas of uncertainty. So a lot of approvals of drugs and devices are on some sort of accelerated pathway. Evidence is more limited now. And so if there's uncertainty in how those benefits and risks will play out over the long term, this kind of analysis can help illustrate that. Also, the potential to flag possible implementation challenges. So a lot of this work came to light around the Hep C issue in 2014, 2015. New, groundbreaking, breakthrough drugs that were going to severely impact budgets, disproportionately impact those budgets that really couldn't afford to pay for them, Medicaid, prison system, et cetera. In other situations like cystic fibrosis, a relatively rare condition, but the pricing of those drugs is also causing budget challenges as well. Drawbacks of this kind of approach. So there may be data and precision challenges here. So a lot of people like to look at the cost effectiveness result as a single result, but this is a model-based analysis based on a lot of assumptions that come from limited clinical data. So the answer really is not as precise as many people think it is. One size fits all risks. So you're doing this analysis largely on population averages, overall populations in clinical trials without necessarily attention, sometimes necessary attention, being paid to those subgroups who would benefit more or maybe be at more risk. One-at-a-time risks. So when you're looking at low-value care, for example, you need to be concerned not only about the particular service or therapy that you're concerned about, but how that contributes to a low-value cascade. There's a lot of research coming out now suggesting that the use of a test, a device, a procedure is part of a cascade that then contributes even more to the low-value situation we find ourselves in. So you need to think more broadly sometimes. And then the other analysis, and this is actually a struggle in other places where HTA is more embedded, like the UK, for example, there's still no straightforward path from finding that something's cost ineffective to disinvesting from it or addressing some of the perverse incentives that Dr. Tuckson talked about in his talk earlier. So with that, I guess I'll leave you with those thoughts, and we'll continue the discussion from here. Thanks.
Thanks, Dan.
Right.
So,
Excellent.
what do we do?
So, following along from sort of those comments, I think I'm going to focus my attention, and obviously, as Bobby said at the outset, I'm mainly representing the kind of payer viewpoint in my experience, specifically at CVS, which I'll talk a little bit about. The thinking that went behind really wasn't so much a formulary. Bobby, it was a plan design, benefit design. I'll get into that nuance, which I think is somewhat important to understand in this area. But I'll broaden it a little bit to talk about, if you think about the main activities that payers engage in from the bottom-up perspective, and you had one on the slide, which is prior authorization. There's a very close relationship to the other things that were on that slide, sort of clinical practice guidelines, and you had NCCN, which is kind of the most preeminent example of guidelines that have been largely used in the kind of bottoms-up decision-making or bottom-up decision-making that payers make in utilization management programs. But increasingly, cost-effectiveness analysis and comparative effectiveness research from ICER and other sources are being used in those same PA and UM processes. So I'll spend a little more time on how those are being used across the board, less about our own, my prior employer, CVS's plan design. And as an independent person, of course, I can say what I really think. So I'll spend the last minute saying what I really think about where we go from here. So just in terms of, what did we do? So we looked very, I think, carefully at the data on whether we were having an impact on sort of overall expenditure on behalf of our, main plan sponsor customers. And a lot of employers had spent, I was there for 7 years, 5 years over and over telling us, you're doing a pretty good job when we look at the data and you sit down and go through our quarterly or annual trend numbers on managing utilization. They were not universally, but, class by class, pretty pleased with what how we were doing at making sure that, utilization didn't go completely out of whack. But we talked about this, and Dr. Tuckson talked about it in his comments. Price was a totally different issue. And usually people think about unit cost, but if you just think about price of new products and existing products, and there was lots of attention on this a couple of years ago. There was a great New York Times article on one drug in particular in the in the rheumatoid arthritis and sort of inflammatory bowel disease area that really showed sort of that the inflationary price increases that have been taken out. That got a lot of attention, and so we heard over and over again, you guys are doing fine on utilization, you're doing nothing on price. We're sick of telling you that we're paying prices that are just, we feel are unreasonable, that are unjustified, yada, yada. So we sat back and said, well, what other trends can we utilize? Or utilize is probably not the right word to use there, but can we take advantage of in order to put together a new offering for our customers who are saying you have to do something about price? Obviously, concurrently, as Dan just alluded to, the whole Hep C, I'll call it situation occurred, and a lot of us that were, sort of living that from all perspectives, both from sort of a prescriber perspective, and I'll disclose my wife is a GI doctor, and so was prescribing a lot of those medications to her patients, and I was on the end of CVS trying to manage the overall picture of budget impact. Because, just to put what Dan was saying in different terms for the Hep C issue, and I'll bring this back to what we did with our plan design, the cost effectiveness was clear. ICER's analysis was clear. It was cost effective. The budget impact was terrible. It was a budget buster. And so I think we all probably recall a lot of the articles that said, this is something that we just can't afford. When the state of California was spending more on Hep C medications in 2015 than they spent on all of education, most people said this is not a reasonable situation to be in from a overall expenditure standpoint. So anyway, so we looked at all of that and we said, okay, what can we do? Well, we can introduce a plan design where we choose a mechanism to be able to try to eliminate coverage for low value, in a sense, prescriptions, care, right? And so where do you go to try to make that distinction? Well, the most systematic, while not completely, sort of ubiquitous, right? Doesn't cover all products that we were concerned about from a new launch standpoint. It covered most, was ICER's body of analyses. And we tried to look at other, sort of sources of cost effectiveness analysis, but starting where the majority of the volume was in the work, we looked there. We quickly, when conferring with experts, said we have to, basically take breakthrough therapy designated drugs or find some way to use a proxy for breakthrough therapy designated drugs out of this evaluation process, because those are supposed to be treatments that are being used for previously untreated populations, patients who there were no other alternatives. So we ultimately said, let's defer to FDA and take that year was 42% for 2017 data of new launches that had been, new launch drugs that had been cleared by FDA that had the breakthrough therapy designation. We said, those are not subject to this evaluation. Everything else, if it's underneath $100,000 per quality adjusted life year, we would then say, for adopting employers, and this is specific to ERISA protected employers, I know I'm a little over time, so I don't have time to explain why we did that, but that's who the target audience was for this. We said those drugs would be uncovered, okay, if it was above $100,000 per quality adjusted life year. That doesn't mean that there wasn't a review process. We assembled a panel so that we could have a panel of experts think through whether or not there should be an exception for any reason. Flawed assumptions in the underlying analysis, different considerations in the patient population, inappropriate stratification, incomplete sort of evidence on whether all of the benefits of the drug had been studied. And so, I'll leave you with that. That's factually what we did. Obviously, as Bobby mentioned, I'm no longer there. I left there earlier this year. I'm happy to talk about what we did up to that point, but after that, look for public, sort of statements from the company. But I do think, just to close it out, it's an important, sort of introduction of another approach in terms of taking action. Because we're responding to the needs of the people who are our customers who are paying these, sort of claims for what they perceive to be, get back to the statement you made at the outset, low value care. So with that, I'll turn it over to Elizabeth, who really has.
Thank you. Thank you. And thank you for having me. I'm very excited to be here. Alan, you had me at affordability and action because that's what our members care about. And employers have often been referred to as sort of the sleeping giants in the system. Where have they been? Why haven't they been driving more accountability for value? I want to remind everyone here, healthcare is not their day job. They build ships, they sell groceries. They did not sign up to fix the healthcare system. But there's this sort of magical thinking that costs just keep going up and it's GDP. They are the ones paying it. Along with state and federal government, it is employers, employees, and their families who are paying these outrageous price increases and for these low value services. So I tend to be a relentless optimist here. And you heard Dr. Tuckson's awesome introduction. Are we there yet? We've been having this conversation for decades. Are we there yet? I would say we are there. And I say that with actually some optimism because our members have stopped waiting for the industry to fix itself and they are taking action. And we actually have some really exciting results to share and would challenge you to join us in this. So as you heard, we have about 40 members. We spend $100 billion a year collectively on healthcare. And we are focused on 3 strategies where we think we will have the most impact. One is investing in advanced primary care. We know that any high-value healthcare system starts with a strong primary care foundation. But we're also looking at purchasing value. We know we spend too much on wasteful services. We're going to talk about that. And then our policy interventions are around creating a functional market, because we have concluded that there are some anti-competitive practices happening that won't be solved by the market. It is going to require policy intervention. And that's why we're involved in the Lower Healthcare Cost Act and some of the drug pricing bills. We believe we need intervention. We have gotten to that point. So you already heard about this. I'm not going to belabor it. But the one sort of real-life example that I would use, so that slide where everything is going to healthcare and it's coming out of the things that make us healthy. My daughter's public middle school proposed cutting sports to pay for premium increases for teachers. So you think about what would actually make people healthy, the money's coming out of there to go to this industry. And this is a quote from Lisa Woods. She directs purchasing for Walmart. She actually also happens to be my board chair. And the point of this slide is that where they are not seeing progress, they are taking action. You're going to see more announcements in October about what they're doing to take action, but they're not waiting anymore. So I'm going to go through just a few high-level undertakings that have actually generated savings and better care. So we run something called the California Quality Collaborative. We've got all the payers in the state around our table, and we are looking at how to improve the value of primary care. So these are the results we released about a week ago from our Practice Transformation Initiative. We saved over $345 million by investing in higher value primary care. We avoided 59,000 admissions, 67,000 ER visits. That is arguably high value care. By investing and helping practices, these are small independent practices, give better population health care, we know that we can actually make a difference in cost and quality. We also operate something with our health TPA partner called the Employer Centers of Excellence Network. This is a center of excellence network for specialty procedures. You'll see the network that we have identified here at a sort of very high level of quality. And just these are some early results that were published in the Harvard Business Review. What I want to call out here is over 50% of the patients referred for spine surgery didn't need it. So even though they were paying more for the bundle in some cases, they saved over $19 million in the first couple of years on total cost of care by avoiding unnecessary care. So this was designed by and driven by employers looking to get higher value for their employees. And when you look at reduced readmissions, reduced post-surgical care, it's better patient experience, better outcomes, lower costs. It is the trifecta. We just released this report about a week ago looking at accountable pharmacy. And what we found was we looked at claims for 15 of our employers. There's up to a 25% reduction on spend. Now, this isn't just theory. We are also working with our employers. Levi's, as an example, just did a proactive review of some of their pharmacy spend and identified $20 million worth of savings. USC is another one of our members. They went in, they enlisted their School of Pharmacy, and they found 40% savings in their drug formulary. This is real available savings, higher value care led by employers. And then finally, this is my last example, but we have very large employer members who are going direct. They're taking it on themselves. Now, I wasn't able to name all of them, but we're talking about Walmart, Intel, Microsoft, Cisco. They are taking this on and going direct to the ACOs to decide what is best for their populations. What do they want to pay for? What do they value? So I guess I would say the good news is they're taking action. They are not waiting for the industry to fix itself. And I want to sort of just raise the bar on your ambitions. You wanted to get some spur to action by the end of the day. This is what we want to see. We want to see actually healthcare spend going down. I think Patrick Conway is going to be here, or he's here. They announced a 5% reduction. It's like defying the laws of healthcare gravity, but it can be done. We can lower costs, and we can put that money back into things that actually make people healthy. So we are all in. We're moving forward, and we are looking for industry partners to make this even more successful. Thank you.
Okay, the fun begins. Start thinking about your questions. Never too soon to start doing that. So Elizabeth ended on a very positive note. Things can be done. And Alan charged us at the beginning. Move from theory to action. So I am going to herd us along, nudge us along, perhaps push us along towards what can we do from the bottom-up approach. So Otis, you referred to gluttony of consumption. Choosing wisely has been around for a long time. We supposedly know things we shouldn't be doing. What can we do differently? Tangibly differently. We've got the NCCN guidelines.
Yeah.
We've got choosing wisely. We've got ICER reports. What can we do so that we don't come back year after year after year and say, well, we're still in the same mess?
In the area of healthcare provision, we need to respect the science. We have too many activities in regards to, in my world of cancer screening that doesn't matter, or cancer screening that actually matters and that it can be harmful. We have tremendous amounts of over-diagnostics and over-treatment. And that's one area. We've got to become much more scientific. We've got to respect the science. We've got to stop doing some things that are just totally just stupid, if you understand.
How do we get there?
We've got to set up the incentives. See, the incentives right now are for everybody to sell something. And that's why proton beam people are pushing proton beam stuff to make money. And they're talking about it being new. We see this in drugs as well. Remember, Nexium and Prilosec were the same thing. It's just Nexium, when it came out, cost $180 a month. Prilosec cost $8 a month. Same drug. Actually, the active ingredient in Prilosec was Nexium, is how I should put it. But for 18 years, it was a $5 billion a year drug because it was the new drug. It was the end thing. And before I lose my time, we've got to start stressing prevention of disease. The average consumption of fruits and vegetables in this country is 2.5 servings per day. In Baltimore, where I now live, it's less than 1 serving per day on average. 5 to 9 is the federal advisory. We've got to start encouraging exercise. We've got to talk about this obesity epidemic. 15% of Americans were obese in 1970. It's nearly 40% now. In certain minority populations, it's 80% of people are overweight or obese. We are causing unusual consumption. By the way, that's an American problem. It is not a European problem.
So I will come back to you in a moment because I want to push you a little bit more. You alluded to incentives. I'm assuming there's fee-for-service kinds of things. So I'm going to come back to you with a question about accountable care organizations, paying for episodes of oncology care. That hasn't seemed to solve the problem either. So we'll come back to that in a moment. So Dan, are we going to end up with, should we end up with an HTA body in the United States, a NICE in the US?
I don't know the answer to should we. I think with the way things have been going and the way things may continue to go over the next 5 or 10 years, I think we will. Now, it's one thing to think about HTA, but it's another to think about how it would then be deployed in a setting like this. So HTA across the globe is not as monolithic as people think. So in some cases, in Canada, for example, the HTA body there that serves all of the Canadian provinces is advisory in nature, so the provincial plans can make their own decisions. In the UK, there's much more of a mandate with binding guidance. So the question is how it would be deployed. But I think given the rise of organizations like ICER and their visibility and the questions that have been raised about value because of the work that they've been doing, I think it's an eventuality here.
And not that I'm supportive of Medicare for all, but let's play out a Medicare for all where it's truly all private insurance goes by the wayside and the government is in charge. Mm-hmm. Do you see an HTA body being central to that?
I do. And in fact, I'd argue that while they haven't had as much teeth as they might have in other settings, there are advisory bodies to Medicare currently that are evidence-based. So MedCAC and MedPAC have provided guidance to Medicare over the years. The use of something like cost-effectiveness analysis has been quite spotty because Medicare, like PCORI, has had something of a chilling effect on their ability to consider that kind of information. But I think the infrastructure is essentially there. Again, whether it's deployed as some sort of government agency or a quasi-governmental organization or just an advisory committee, I'm not sure. But if there is a Medicare for all scenario, I would expect that there would be some sort of independent body providing advice to Medicare on cost-effectiveness questions.
Surya, what do you think here? Are we headed in this direction? If we are, one of the underpinnings of an HTA assessment would be a threshold. You know, CVS had its benefit design, thank you for correcting me, at 100,000. You guys invented that number. Those guys invented that number since you're no longer those guys. Where should that number come from? First of all, are we headed in this direction? And if so, who is supposed to anoint the threshold?
So again, just to connect it to Dan's comments, I think we mostly agree, maybe not completely, just in terms of the sort of crystal ball part of it. What do you think is going to happen? I think an advisory function is much more likely than any kind of binding authority, which would follow along from most of the other advice that even in a Medicare for all scenario, that there would be an advisory function. But just let me focus on the threshold for a second. So when you do the calculation, it changes based on the exchange rate that NICE uses in the UK. People always say it's around $50,000. Right now, it's around, like I did it the other day, it's around $41,000 per quality adjusted life year is the current exchange rate, what it comes out to. Without a sort of binding authority or the recommendations that the body would make, I think it's unlikely that anyone, even that committee, would be the one that says this is where the threshold lies. So I mean, just practically speaking, instead of answering who should make that decision, who will make that decision, I think we're likely to continue to have a multi-payer sort of environment and system here. And each one of the payers is going to have to decide for their constituencies and for their, given all the, the things we've already talked about, budgetary constraints and other things, where does that number lie? Because I know this is the bottom-up panel, but there are top-down considerations in how you set that threshold. It's not all a bottom-up driven decision. That said, my own, this is the part where I just, tell you what I think. I mean, I think in the world of pharmacy, in the world of drug, there's a need to be able to set a threshold for relatively common disease where you expect a lot of prescriptions to be written and a lot of volume. There's a threshold for rare, there's a threshold for ultra rare, and then you layer on another dimension of how many alternative treatments are there in that sphere? Are there other things for the, in shared decision making for the patient and the doctor or prescriber to consider? If there's not, then you have to take a different lens. And so I think there's not one threshold. And that was never the intent with the program that I ran, that we introduced, was not for there to be a single threshold forever. So we actually wrote at the time that we released it that there was a different threshold that was still up in the air for rare and ultra rare conditions. So, sort of back to the question though, I think, yes, we absolutely do need to have, sort of a basis for better HTA or more consistent HTA to be done here. The problem has been that it's inconsistent. You don't always have the same sources of information, and certainly not the same rigor in all cost-effectiveness analysis and comparative effectiveness research when you're trying to perform as the payer health technology assessment.
Elizabeth, you described some positive examples. So Reed had his long list of what was in his toolkit. What do you think are the most powerful tools in an employer's toolkit?
Well, there's a lot to choose from, but I mean, they're buying the care. They are the ones purchasing the care, so they can set incentives. And as I mentioned, some of our members are doing prospective bundles that give the providers far more flexibility in how they deliver the care, but there's also a warranty involved. So that changes sort of the dynamic there. They're having direct conversations around primary care and ACOs, and what people need to remember is that employers and physicians want the same thing. Healthy patients are healthy employees. So when they get all the sort of noise out of the middle and they set up relationships where they understand that they're both aiming for the same thing, you can have really effective approaches. Reducing some of the measures that don't add any value. Creating more flexibility in payment so they're not getting permission from the insurance company. There are a lot of opportunities there. There are also some technology opportunities, and we still haven't solved data sharing. We have hoarded data in this industry as though it were some asset of a health plan where we really need it to actually improve patient care and population health. That's not a technology problem, that's a business problem. There are just more opportunities than I can even address, but again, going direct, that's one of the biggest levers, changing payment and incentives, reducing unnecessary measures that reduce administrative burden, and really just designing their care delivery. So we saw last week, Walmart's actually designing their own primary care centers. And it is actually including a nutritionist, including behavioral health, integrating care to address all aspects of health that you heard Dr. Tuckson talk about. So it's really, it's not a matter of adequate tools, it's a matter of actually using them, and I think that's what we're starting to see.
Otis, it sounds like you have a perspective here.
I was sort of laughing because I'm starting to see Walmart as the solution to many of society's problems. In a positive way. I'm being very positive here. What we really need is attitudinal transformation, both in how we pay, how we consume, and how we provide. And what we really do need is some social responsibility, and what we have not seen. And unfortunately, many of our voluntary health organizations, many of the many organizations that should be representing the population have actually defaulted in doing that. What we really need are people who are agents for the population. Right now we've got organizations that represent the drug companies. They're trying to lobby for more reimbursement for drugs. We've got representatives. There's even one for Proton Beam, by the way, a patient organization that has draft letters that this is what you send to your congressman to get more reimbursement for Proton Beam. I'm hitting on Proton Beam a lot today. I can hit on the drug companies, other device manufacturers. I can hit on the health insurers, the hospitals. I mean, everybody has got, including the patients, need to start having some responsibility, and we all need to grow up. And your word, transformation. Mm-hmm. We need an attitudinal transformation on all parties about how we both pay for, consume, and provide health care.
So I've been at this for 30 years of low-value care, and I have every scar to prove of that. And I went down we have to teach doctors what's needed. We have to change attitudes, blah, 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 blah. You didn't do any of that with your spine surgery back pain example. You just sent them to particular centers, and it all happened. I mean, you showed a 50% reduction in back surgery. what did you do? Because I don't think it was the stuff we just been talking about. I think you somehow said, go there, not there, and it miraculously happened.
Well, it was a little harder than that, but.
Darn.
Well, first of all, part of our work is we are also measure developers, patient-reported outcome measures. We are steeped in quality. And we actually created, and again, this predates me, but quality standards by which each facility and each provider would be assessed. And it is a very high bar. And then our teams went in and actually met with the surgeons, with the facilities to say, can you reach this standard of quality? And we were very selective, or again, they, because this predates me, they identified those with the best outcomes. They actually did the work to go in and identify the top performers. And then it was gradual, because at first there is a real challenge among employers of employee disruption. That is sort of a kryptonite for change. But they started with a voluntary benefit that you could travel to these top sites. And over time, as the results have proven out, and it's not just avoided surgeries, it's patient experience. There are employees coming back saying, we didn't even know healthcare could be like this. They felt cared for. They felt like their care was stewarded by the physicians. So as that track record has been achieved, it's moving more towards mandatory benefits. So it is evolving, but it is not an easy lift. And again, this is not their day jobs. But one of the other unintended consequences of this wall we've just run into is that this is becoming more of a C-suite issue. So you have CEOs of major employers around the country in tech and others saying, we have to get involved. This is a strategic issue now. So you're going to see, I think, more and more transformation.
Surya.
Yeah. So
Maybe we shouldn't be evaluating individual services. We should just figure out what providers to send them to and let the magic happen.
maybe in some situations that would work. I mean, but let me just sort of look through this prism from a different vantage point for a second. So. And this is not meant to say this, because I think the reduction in spine surgery, that is a good metric to look at overall, and I think that maybe sort of is indicative of the work that these high quality providers are doing. But one of the problems we've had, I think, is choosing something that is a general metric and then trying to apply it more broadly. And what I mean is, this is about sort of and let's just, since he sort of gave the opening keynote, let's reference it back to what Dr. Tuckson said. Okay, Hippocratic oath and money. Oh, we're all focused on the money now, not on the morals. But at the same time, he closed out saying that we can't have everything for everyone. And here we have a program where we're saying, okay, it's higher quality because we got them to the right centers, and the number of spine surgeries went down 50%. Well, I've had the privilege of practicing medicine in a lot of great hospitals and medical centers. Not getting surgery is not always the right answer. I know that's not what we're saying here. But there are situations where getting spine surgery is the right thing. That's the right thing for that patient. And so it's more about, and I know this is a little bit of a buzzword, but I'm going to use it anyway. It's more about being more precise with when the procedures get used, not just responding to the incentives. And it is about the money, I think, in most cases, that economically people and systems are incented to do the procedure. And that's why you see reduction, and that's higher quality for now. But when that same paradigm gets applied in other care settings where it's not the centers of excellence that you have right now in the network, and everybody else says, oh, well, higher quality is doing fewer spine surgeries, and that's out in centers where you don't have the best infrastructure that makes the patient feel cared for, because I guarantee you, it's not always the surgeon in those situations that make the patient feel cared for. It's all of the other care providers. Absolutely. It's the entire multidisciplinary care team. That infrastructure doesn't exist in every center that does spine procedures. So back to the problem that he introduced also, that Dr. Tuckson introduced, of what are we going to do with our rural hospitals? One thing that's happening is a lot of the other staff that helps the patient feel cared for and make sure that post-procedure, post-operatively, they do well, they get cut because the hospital is struggling to survive. So we have a kind of a number of different vectors that lead us to a situation where we could have a set of metrics that we come up with that look great on paper, and we say they came out of these programs where the number of spine surgeries went down, and then we try to extrapolate from it and put it in other areas because we're trying to help these hospitals survive, and they perform well on those metrics, but the care the patient gets is actually poor. And just to sort of take another step back, because I think we all are in some way connected to the patient and caregiver viewpoint. Myself right now with my aging parents, and it's incredibly human to say, I want the best thing for my loved one, for my family member. But if best is measured as, don't get the unnecessary surgery, then and that starts to get ingrained. That has its own set of issues too, instead of just, I want everything done. So all I'm saying is just, we have to temper it a little bit with let's understand what we need to do to try to, again, I'll use the buzzword again, to try to push the uptake of precision medicine, of more precise healthcare, the right thing for the right patient at the right time. And we're not talking about that so much right now because we're talking about, how do you make these individual decisions, but anyway.
Yeah,
Okay, we're just about to go to questions from you guys, so get ready.
Can I just throw some?
Okay, Dan, Otis?
Yeah, just quickly. So, and I'm going to pick on proton beam again. But, so putting cost effectiveness aside for a second, why can't we envision an arena where we're just thinking about evidence-based reimbursement? So there are places in this country, Detroit, Ann Arbor area, for example, where there are 5 proton beam facilities down the street from each other. In Boston,
Here,
in
right
DC,
here. Yeah.
And in Boston, where Mass General was one of the first in the country, there's still only one. In part, I think, because commercial payers, and I know Medicare also plays a role here, but commercial payers have said, there's no evidence it's any better than the other standard of care, IMRT. So you can do proton beam on a prostate cancer or a breast cancer patient. We're just not going to pay you anymore for it. So this is evidence-based reference pricing as opposed to the Trump administration version of, we want to pay what other countries are doing. There's a whole other stream of argument about how those prices are defined by HTA processes anyway. But why not just say, we will do an evidence review. Don't even think about cost effectiveness yet. We'll do an evidence review. If there's no compelling evidence that it's any better, whatever service it is, we're going to pay you the prevailing rate and see what happens.
Yeah, my comment was actually very much in keeping with what you just said. One of my great concerns is many Americans, both professionals in the medical system, as well as consumers, as well as payers, do not appreciate science. They just do not understand and appreciate the evidence and evidence-based medicine.
Yeah.
That's the problem. I've actually had I've actually had arguments with major political individuals about the scientific method. And as I was arguing, I realized they didn't know what the scientific method was.
Yeah. Yeah.
Elizabeth?
Yeah, I would just add, first of all, I think employers would love to pay for scientifically based treatments. It's very hard for them, in their day job, buying benefits, to really know what that is. They depend on the medical community to do that. And there's a tragic lack of transparency in the system. How do you pay for value if you can't identify it? And if you don't know the quality, if you don't know the outcome, if you don't know the price. So they are trying to do that, but they do need partnership. And then just lastly, I want to correct any understanding that we are just focused on avoiding surgeries, because on the contrary, there are multiple strategies that are being looked at to actually improve health. Again, investing in primary care, investing in population health, but at the same time, there is really low-hanging fruit on unnecessary services that we also need to look at, because it is actually in the best interest of patients. So it's a comprehensive approach. Just a few important examples.
Okay, so we are ready for, well, there's no questions, so we'll just continue. Let me counsel the questioners. A, there must be a question here somewhere. And B, this is the bottom-up panel. So please don't have a question that takes us to later points in the day. You'll have a chance for later points in the day. Please. Introduce yourself and...
Michael Cook, I'm a healthcare lawyer, and I'm also on the Medicaid board in Virginia, and I've counseled some political candidates on healthcare. I've advocated and gotten beaten down very hard for getting rid of employer-based health care instead of moving people, everyone into the pool with a whole lot of protections in there and bargainers. I recognize that that'll scare the hell out of too many people and gore too many oxes. How do you make what you're doing replicable in smaller or mid-sized employers? In other words, how do you spread it?
I love that question because you would be surprised at the lack of leverage even some of my jumbo employers have in the market. It is remarkable how many folks on the other side just say, no, we're not going to do that. We're not going to create that bundle. We're not going to change our, our quality reporting. What we are hopeful of, though, is that as we learn what works, we want to share that and help make that available to any payers, any purchasers in the market. And we believe that there's evidence that we are generating, like in the drug spend analysis, that we want to make available. But they don't have the leverage by themselves, to your point. So we think it's going to take collective action, and if we can get our members working with other like-minded employers of all sizes, we think it'll drive some change.
Let's do some rapid fire so we can get a bunch of questions here. Yeah, you. Microphone.
Thank you. I'm Dr. Caroline Poplin. I'm a primary care physician, also an attorney. I've been very involved in off-label marketing. We sued lots of people. I know PBMs and the patents. Why are we not talking about President Trump's one good idea, which is to not reinvent the wheel, but to take the prices from overseas? That's what Dr. Tuckson said was a big part of the problem. The prices of drugs, they're set at whatever the market will bear, and a good example is insulin.
Any thoughts on the price side? Clearly, when I introduced the topic, it's stuff we don't need. It's done by people who may not be the optimal folks, and prices that are high. Now, this applies to surgery, it applies to proton beam, it applies to drugs. But the question has to do with drugs and foreign prices. Is this a direction that would, well, that's getting rather specific, unless one of you wants to speak to insulin.
I can make a general comment. I mean, yeah. I agree with you overall. I mean, if I just characterize it, though, if a reference-based price for a list of services is the direction that we're willing to go in, I think that's great. Personally, my issue with that plan was, why are we deferring to the HTA process from a scattershot of other countries? We don't have the analytic capability to do that ourselves. I mean, we do. Well, because I think there are unique circumstances. Sometimes that I'll just say, having looked at them, sometimes I don't think they were great analyses. I mean, and Dan can speak to this too, but there are times when I think it would benefit us to do our own. But the overall concept of why are we not using that system of reference-based pricing, it defies logic. Back to Dr. Brawley's comment about rational, that is rational to change.
What I don't understand is why there's a law that says Medicare cannot negotiate price. I will tell you that the Veterans Administration and the Defense Department hospitals do negotiate price. And you will frequently see something that Medicare will pay 10 times as much for as the VA or the Defense Department will pay because of that. By the way, I can answer the question why Medicare cannot negotiate price. It's the same reason why we don't have background checks for guns. There is somebody who is paying for that. Yep.
Let me just throw in as well, understand that even the best HTA process is a snapshot in time. The issue we have here that doesn't exist anywhere else are the price increases over time. That's obviously the issue with insulin and with many other drugs as well. And so I think we have to break those two apart and think about what sort of process could end up arriving at a reasonable price at launch, and then what do we do with price increases? Right now, this is all market-driven, and the decision's up to the manufacturer. But in any other country, it's that either does not happen at all, or if it does happen, it's tied to general inflation or something like that.
Yeah, in the back there.
Hi. Carl Polzer, a longtime health policy analyst. I have a recent article in the Health Affairs blog about the Cadillac tax and some of the underlying drivers of this issue. I have a futuristic question. So Dr. Tuckson was right in the whole system. You know, there's a big recession, lots of cataclysm, Democrats take back over. 20 years from now, there's real serious discussion about Medicare for all, okay? But the employers want it, there's also pressure to have some semblance of the employment-based system left, carved out, so large employers can keep negotiating. So you're going to move all the ERISA plans over to HHS, but so you're going to have three different buckets, 3 or 4. You're going to have traditional Medicare, you're going to have the residual individual market, they combine the Medicaid and the exchanges, and then you're going to have the employer market now under HHS. They're all going to have cost caps. How much liberty do you give each of these 4 buckets? How do you do technology assessment for each bucket? And what would you do different? I mean, right now Medicare the contractors have some leeway, I think, in different regions to make coverage decisions. How would you keep the employers involved, and would they be able to do more, you know, do less rationing? That may be where we end up. Question.
Any comments on his points? Elizabeth, do you have anything?
Well, it's hard to comment because it is pretty hypothetical at this point. You know, employers aren't monolithic. I think there are some who wouldn't mind if, you know, there was an alternative for them, you know, doing the heavy lift of offering insurance. But there are others, and I've seen this particularly among public employers or employers who know they're going to, you know, have their employees for generations, that they're all in. They're invested in the health of their employees. So again, I think the same standards would apply. They want evidence-based effective medicine at a reasonable cost. So, I mean, I don't see that changing.
Okay, we are just about the end. So we have 2 things to do. 1, each of the panel members, what one thing would you recommend to the audience that they focus on to do something about the bottom-up approach? You have 1 minute each. And for the audience, I'm going to ask for a show of hands, how many of you feel at this point, the end of the discussion, after their 1 minute whatevers, that the bottom-up approach is an important part of the solution? I'm not going to define whether it's over 50% or under 50%, but 1% is not part of the solution, 95% is, so a substantial part of the solution after what all you've heard. Okay, 1 minute. Otis.
I'm going to go way out from left field. We need to fix 2nd and 3rd grade. We need to educate 2nd and 3rd graders about health care, about how to eat, how to exercise, how not to smoke, how not to drink, how to actually think about science. Some of that will actually go home and influence their parents' attitudes and influence what they have on the dining room table. It's a long-term investment in prevention of disease.
Okay.
And it's a long-term investment in changing the American attitude about how we consume medicine.
Dan, what one thing does this audience need to think about?
So how about the idea of an advisory but comprehensive HTA body for this country that reviews clinical evidence and provides advice on whether additional reimbursement is justified for a new service, does an evaluation to understand how cost-effective the price of that service is and whether some pricing relief is necessary, and works with the clinical societies to set evidence-based clinical guidelines that are not necessarily prescriptive, but singular in their attention to whether evidence justifies the use of a service.
Surya.
So I'm going to go with we're sitting on a huge amount of, sort of unprecedented amount of data and information to help us drive decision making, and a lot of technology that could, assist with that. But Elizabeth said it before. There's in reference to a different issue, but it's a business problem. We've got to make sure that we're, sort of taking the handcuffs off of that, understanding what the privacy concerns are, and using the best. And I'm not saying technology is the savior, but if there's one thing we can do, it's, this goes back a little bit to what Dr. Tuckson was saying at the end also. If we're unified, lockstep, saying all of us that instead of worrying about, sort of, we're in DC, so lobbying or supporting only the things that are going to help our own bottom lines, so to speak, but thinking about what's going to help our industry get out of the trap that we find ourselves in, the death spiral, we'll be better off. And I personally think that being able to work together to create the kinds of databases that we're going to hear about over our lunch talk would be a big step in that direction.
Elizabeth.
It's hard to choose, but I'm going to go with improving behavioral health. It is the top priority for most of my members. There is no mental health system that is functional in this country, and it drives so much need, and including sort of childhood trauma, really looking at behavioral health needs and integrating them into care. Sort of at a more abstract level, though, I would go for this collective accountability. We have got to be stewards of this system. Where are the board members of these hospitals that are gouging prices? Where are the board members of these companies that, you see these stories all the time of people not being able to afford their insulin? We have got to have a different approach to our collective accountability for this system.
So, in my notes, we've got the extremes. So we've got an HTA body that would help us through some of this. We have data that will help us work our way through this. We have to address behavioral health and second graders. That's pretty broad. But I think the collective need that we work together to solve it, I think, is a common theme throughout what Reed said and what you guys have said. So now, you guys, as always, will have the final word. So, show of hands. I may have to stand up because I can't see with all the lights in my eyes. Whether you've brought this belief into today or whether that belief has been altered based upon what you hear, you're not going to injure my feelings or one way or the other. How many of you feel that the bottom-up approach has a significant role to play in solving our health spending problem? How many of you feel sounds like a good idea, but it's not worth huge efforts to throw at it? And how many of you are still confused? All of us, but all right, well, I'm cautiously optimistic that there is a play to be made for the bottom-up approach. And now we'll see if the top-down approach feels as good to you guys at the end of it. And then the final panel on the future will tell us where we go from here. What do I need to tell them for lunch? You will tell them. Please help me to thank our panel.
As we go into our lunchtime address, I do want to once again thank those who've made today's event possible. In addition to the lead support of the National Pharmaceutical Council, we have the Alliance for Community Health Plans, the American Cancer Society, Blue Cross Blue Shield Association, and the Council for Affordable Health Coverage. We appreciate their support to make today possible. It's my pleasure to introduce to you for our lunchtime keynote, Robin Gelburd. I don't get to introduce lawyers that often, but I am one, and so it's nice to have another one on the podium here. Robin is the founding president of Fair Health. She'll tell you a little bit about the organization. She comes at this after practicing law and serving as counsel of a research organization in New York, so she brings a history of focus on research, and that's what the work of her organization makes possible. As we were discussing in advance, we've talked about bottom-up, we've talked about top-down. In some sense, she forms the middle, and it seems appropriate in the middle of the day to have that perspective. So please join me in welcoming Robin Gelburd.
Thank you, Alan. It's a pleasure to be here today and to contribute to this really vibrant discussion on health spending. And as Alan mentioned, we're probably perfectly situated where we are when you learn about our unique origins. So for those of you who are not familiar with Fair Health, I really am not aware of any other organization like it or was created in the same manner. We were created a decade ago out of an investigation brought by the Office of the New York State Attorney General into the way in which consumers were being reimbursed for their out-of-network services. When they looked into it, they determined that there were certain, at least apparent conflicts of interest in the data products being used by insurance companies to adjudicate those claims. So what happened was it never went to trial, there was a settlement, and out of that settlement, it was agreed that a new paradigm should be created. A new independent national not-for-profit organization was created, and we were tasked with creating a data repository of healthcare claims that could be trusted by all stakeholders, that would be really evaluated, vetted, and using the best methodologies and algorithms to create data trusted for benchmark products as well as custom analytics to both inform policymaking, federal and state officials, as well as health systems, health plans, and everyone else in this healthcare ecosystem. The crown jewel of this settlement was considered to be the mandate to create a free consumer website that could bring unparalleled visibility into healthcare pricing for consumers and really arm them with the information they need to make sound decisions. We have a premier board of directors who are uncompensated and roll up their sleeves without conflicts of interest to really help us noodle through the difficult questions. I'm pleased to say Chris Koller, who you will be hearing from after my presentation during the afternoon, I guess in the top down, is one of those board members. And again, truly fortunate to have them. So what do we have and what gives us the ability to really bring you into what we're seeing in terms of a variety of different healthcare trends that have true impact on healthcare spending? And again, we are completely neutral and unbiased, which is why we've been slotted in at lunch. We're not bottom up or top down, but we help inform both bottom up and top down decisions. And the way I also think about it is our data help inform at the macro level, making really system-wide changes, as well as the Mrs. Jones that Dr. Tuckson referred to earlier to really help her decide where she should go for her care and at what cost. So in addition to what we have let me just go back, are over 29 billion records. These are private healthcare claims that have been gathered both self-insured from employer plans and fully insured. And why the self-insured is so critical to analyses, as you know, the Supreme Court not too long ago ruled that in the Gobet decision that all payer claims databases are not permitted to mandate the collection of self-insured data due to ERISA preemptions. We get that data voluntarily, and that's a very critical part of the healthcare system, so it helps us round out the analyses we do. That data cover approximately 150 million lives in the nation. It's representative in all 50 states. And what we do is when we take in the data, we organize it into very discrete medical markets, 493 markets that tend to track with the first 3 digits of a zip code to allow people to really see the heartbeat of the individual medical markets, or if they like to roll up data to counties, medical service areas, states, regions, or look at urban-rural comparisons, which are quite interesting. Because of that data, we have been certified by CMS to serve as a national qualified entity, and therefore have been entrusted with all of parts A, B, and D data to help inform, again, a broader view of the healthcare system, because with our private and with the Medicare, we're almost like a de facto national multi-payer claims database. The data help, it's sort of interesting, people have been talking earlier about the need for data, and it's almost become like photosynthesis, the way flowers sort of lean to the sun. Stakeholders starting to now lean toward data, the need for data to make decisions. That's happening at the federal level, where we're being asked, for example, by GAO for air ambulance data, or the CDC is looking at various clinical corners, or the USDA looking at food allergies, recognizing there's an important need to study actual data to take the guesswork out of decisions. Because as mentioned earlier in the early keynote, the time is now, and the time is here where really action needs to be taken. So what I'd like to do is take this ocean of claims, and this is what we try to do generally, which is very opaque if you just look at it from the outside, but to really bring you along and almost like on a glass bottom boat, take you into that ocean of claims that we receive to see what we're seeing, to see the trends that we're seeing, the trends that can really point in the direction of some sound policies that may bend the cost curve, bring greater value, really lead to more effective outcomes. And so toward that end, obviously it would take really a multi-week symposium to go through all that we're seeing. For purposes of time, we've teased out a few examples to give you really sort of a concrete taste of how the data can be quite revealing of the various threads going on, or transformation, one can even say, and it's happening. So one of the things that we're seeing, and one transformation quite apparent, is the patient migratory patterns now. It was mentioned how employers are taking certain steps right now. Well, so are consumers and patients, and they're making certain decisions. And there are certain offerings now in the ecosystem that are upending the way patients typically had accessed their care. I'm talking about telehealth, retail clinics, urgent care centers, ambulatory surgery centers, home health, which we're not featuring today, but that's another component. And want you to see the blurring of the lines between those venues, because it may, one, cause you to scratch your head at first, but then make you realize there are some opportunities here to really see what's working from just a care delivery model in terms of cost. However, before getting into the data itself, we should recognize that this transformation in the healthcare ecosystem in terms of site of care raised some really significant, really profound questions that go beyond cost. And that really goes to one, you'll see quite clearly that blurring. So people are having to make decisions, and how do we properly direct patients to the appropriate site of care? Well, they will be receiving potentially different services, but even if it's the same services at different costs. And then there's also varying reimbursement models, because there are very different payment streams flowing to these different venues, both in terms of what's being billed by the provider and what's being reimbursed by the payer. There also, the fact that you have these new constellations in sort of the primary care sky, if you will, there are care coordination and care management challenges. How do you ensure that that visit to the retail clinic or the urgent care center or that encounter with a telehealth provider somehow feeds into the patchwork of that patient's network of providers, to make sure that it's more helpful than hurtful, it's not causing duplication, that we're moving sort of the ball forward in terms of care and efficiencies in the healthcare system. And then, before we just dive into the data, benefit and provider network design. That's really essential, and that's where the feedback loop comes. As our data begin to show some of these varying elements, it can be ingested by decision makers at the plan level, at the health system level, and really cause decisions as to what should be covered and at what cost. And so that sometimes is driven by applicable statutes and regulations. That's sort of the overarching backdrop, because again, and that's where fair health, we talk about bottom up, top down, we're sort of at the macro and micro level. At the macro level, statutes and different states and different jurisdictions are looking at this data about these venues of care to see how states should liberalize or restrict use of these different settings. For example, some states restrict what can be done in a retail clinic, at what ages, or what can be done through a telehealth setting, and what are the malpractice laws associated with that. There are real complexities associated with the different venues, but it demonstrates a real appetite to broaden the primary care landscape, provide access to those that are really new to the really insurance environment. Even though that seems to be constricting a bit, there has been a flooding in of new entrants to health insurance. So let's really, to make it more concrete, let's look at the data. So here, this is showing you the top 8 diagnoses presenting in an emergency room in 2018. And then we'll look at some other slides that'll really show some of the issues we've been discussing. So general signs and symptoms, that's malaise, headache, fever. You'll see things that aren't really surprising: digestive system issues, acute respiratory infections, joint tissue, injury to body, so on and so forth, urinary infection. Now what's interesting is you don't have to memorize the prior slide, because what we did to try to illustrate this, we've moved forward into that blue box the five diagnoses from the emergency listing. And what you'll notice is for urgent care, these are the top diagnoses in urgent care. All of those 5 are covered in the urgent care listing. Again, evidencing that blurring of the lines, that people with the same diagnoses are moving through these different venues, sometimes not knowing that they're doing that. For example, in Texas and Arizona, where you have the freestanding emergency rooms, oftentimes patients think those are urgent care centers. So education is key to that. I know it was mentioned earlier about educating 2nd and 3rd graders. Really, it's important to continue that education to those who are really accessing care. Now let's move forward to retail clinics. 2018 data. Again, so you didn't have to memorize, look at the 5 in the urgent care box to the right. Number 1, 3, and 5 all appear on the retail clinic list. Again, showing the broadening of services being provided at retail clinics. It used to be that's where I would drag my 3 sons for their flu shot. People are now getting full office visits there, 25-minute office visits, and all of these services. And what really brings home the fact that retail clinics are now truly among sort of the primary care providers in an entrenched way, you see a chronic condition listed there among the top 8. Previously, you would always think of chronic care as being rendered by your normal primary care doctor managing that condition. People are going to retail clinics for that type of maintenance. Rather unusual, and we're seeing that trend increasingly. Now turning to telehealth. So let's put the mental health to the side for the moment, because I want to come back to that. But again, the remaining 7 diagnoses listed here for telehealth, you will note have all been covered on one or more of the other slides, including the chronic respiratory disease. So again, telehealth is increasingly being utilized. And about mental health, what's fascinating is, as you'll see in a later slide, more than other services in mental health, for telehealth, there's parity, close parity between what's being reimbursed in an office and through telehealth for mental health. And to the point brought up by Elizabeth when she mentioned behavioral health earlier, we're seeing alarming trends. While not the topic of today, we've done a lot of studies in mental health from 11 to 21-year-olds, alarming increases in depressive disorder, anxiety disorders, so on and so forth. Having a telehealth outlet for a teenager to really be able to access that, or other individuals, has allowed for attention to what seems to be sort of a growing issue. So let's move from looking at the common diagnoses presenting at these blurred lines of venue to the actual prices associated with it. While Fair Health collects both billed charges and allowed amounts, billed charges being the non-negotiated amount that's billed for either out-of-network services or for those without insurance, and the allowed amounts, which are the negotiated amounts. We're not going to bombard you with every view in every instance, just in the interest of time. This is a national comparison of charges for emergency room costs and urgent care costs for common radiological services, x-ray of the chest and of the wrist, ankle, and foot. And suffice it to say, without going into the specific numbers, you can see the emergency room is in blue, the red is in urgent care. You could see the delta there. Now, these are very common procedures, so multiply that millions of times, and you'll be able to start seeing the impact on the healthcare system writ large in terms of cost. Here is an established patient view both 15 minutes and 25 minutes, the most common CPT codes that really run across the spectrum. And here we're just juxtaposing the various venues: office, retail clinic, urgent care, and telehealth. And again, 99213 is 15 minutes and 99214 is 25 minutes. And you can see how these choices impact what the ultimate out-of-pocket cost is to the consumer and what the cost is to the payer. And again, those kinds of costs factor in, because at the end we'll talk about those interdependencies. But again, you can see the array. Here is looking at the allowed amounts, meaning the negotiated amounts, again, for those same services. And what's interesting here, it's shifted where telehealth actually is being reimbursed higher than the other venues for these office visits. So again, different choices are being made. And what's really fascinating is to take the data and then, almost like a baton, pass it on to other policymakers to really look under the hood at some of the explanations for this. Here, we're looking at the 99213. We've broadened the view. Instead of looking at a national level, we're now looking across 3 states: California, Minnesota, Texas. Just to give you a flavor, while at the macro level, it's interesting to see the differences among the different states, focus more in on the micro level within the state of choices between venues, because that's where the patient and the plan or the provider can have an impact in determining where care may be sought. Again, you can see, for example, in Texas, it ranges from $68 for telehealth up to $153 at an urgent care center, whereas in California, it's $97 a retail clinic, up in outpatient, an outpatient facility to $219. Again, just not wanting to dwell on the individual numbers per se, but just for you to get a flavor for the hierarchy of charges and the different venues and how they sort out. And this goes back to what we mentioned earlier about mental health. Look how close these common 45 and 60-minute visits psychotherapy are, in terms of an office visit and telehealth. So there may be providers who, realizing there may be some equitable levels of reimbursement, enticing them to participate. The need is clearly there for additional services, as we're seeing mental health reasons really grow in the repository. So again, depending on the type of diagnosis or service, there could be huge deltas between these different venues, or those gaps may be closed as people recognize access is important for certain types of services. So we talked about the same diagnoses presenting at the different venues, and we talked about the same CPT code, how they vary at the different venues. I'd like to just pivot for a moment to look at the treatment protocols, because that, again, goes to the early discussion this morning, the huge opportunities in looking at what is effective. Are people looking over the fence at their neighboring states to see how are they treating this condition? Who is learning? We see wide disparities in care for the same condition, and we thought it would be, to just take one example that can really help spotlight this, is with opioid abuse and dependence. Fair Health, not only do we give out our data to researchers, when we feel we are uniquely positioned to really dive into an area of public health concern, we will, and issue white papers, just again to bring people out on that glass bottom boat. We did that in opioid abuse and dependence, and our last August 2018 white paper took 50 states, and we did really basically a tapestry of the country, isolating what are the 5 most common procedures rendered within a state for someone with opioid abuse and dependence, what are the 5 most expensive cost centers, and you can only imagine the variation. We're not going to bombard you with 50. They are available on our site, free, just interactive, and you're welcome to go through them yourselves. We just took different regions just so you can get a flavor. Texas, Illinois, California, and New York. Just to orient you, where the color is the same, it means that there's commonality. That's the exact same CPT code across states. Where you see white, that means there's no like partner in another state using that procedure among their top 5. So again, you could see that tapestry developing, and it also shows certain proclivities. For example, Texas, very heavy on drug testing. Illinois has made use of medication management, but they use naltrexone most commonly, whereas New York uses methadone. So the question is there one that's working more than another? What kind of studies could help really create less of a wide tapestry? Here's by cost. Again, you see a lot of white, and you see, other than the drug tests, which appear in every state, very different directions the states are taking to address what has been an opioid epidemic. Even more starkly, if we just take the top 3 most frequently performed services in a state across the 4 and array them by cost, you can see the impact on the healthcare system writ large. You could see that Texas has $2,033 for their 3rd most frequent, whereas the 3rd most frequent in Illinois is $5, and it goes on. So you could see the choices, the clinical choices made, have true financial impact. And it's not to say that costs should drive that per se, but the data should really help determine what's working. Who's returning to the emergency room? Are there more people ODing with one protocol than another? And you could see in terms of reimbursement, it follows the same type of hierarchy. Likewise, in the most expensive, if you tease out the 3 most expensive services across, you could see, again, how these various choices are really impacting the system. And those same bill charges result in a similar hierarchy in terms of what is being paid. So I'm glad that they mentioned sort of 2nd and 3rd grade and bringing and educating children about healthy lifestyles. I know my sons were really benefited by the DARE program with cigarette smoking. We did a survey that showed over 77% of people believe that they should be learning about health insurance in high school or college because they have no idea how to manage their health benefits and understand the health insurance system. As I said, the crown jewel of the Fair Health settlement back in 2009 was to launch a consumer website. We took that mandate seriously when we were handed the baton. And what we did was we offered both of you into the non-negotiated amount for those without insurance who are seeking out-of-network services. And we offer the estimated in-network amount. And that became critical because of the high deductible health plans. People needed access to at least an estimated in-network amount so they would know how to plan for their costs before they hit their deductible. What we also found is to keep really moving forward in terms of health insurance literacy. For the first time, we are thrilled. We received a grant to really work on a groundbreaking project to pair clinical decision aids with financial information. That has really been lacking. There are some shared decision-making tools out there, but they have never had the opportunity to incorporate data into those to really broaden the conversation. Many patients had asked for that. And so our initial foray into that is with palliative care, and we hope to move into preference-sensitive conditions. So working with certified clinical decision aids, that's not our sort of bailiwick, but our data are able to really properly get married with that. And we thought, what we typically do every year, people say that consumers aren't really accessing price transparency tools. There's some thought of that. We don't find that. We get thousands and thousands of visits, and every year we list the top 10 medical and dental codes being searched. Here we just picked the top 5 to give you a flavor. But I thought it'd be interesting to see this slide, because when we onboard consumers onto the site, it's completely confidential. We don't take names, but we do ask for a couple of things. We ask if they're insured or uninsured, and we ask if they are seeking in-network or out-of-network care. One, it helps us understand or how to pair them with educational content that we have on the site, but it also helps inform us to know, well, are there more things we can be doing based on the population coming? And it's been fascinating. So uninsured, 14%. So 14% are really looking for the full freight price and maybe to get a sense of how they can negotiate with someone that may be charging more than that. And then look, we were really surprised when Fair Health was first created back in 2009, the focus was on out-of-network services, not the surprise out-of-network services that are now currently the topic of state and federal legislation, but where someone is intentionally going out-of-network, they know that they may have to pay more, but they want to really have to pay a fair amount. But what's fascinating is the in-network population has increased to 26%, and that goes to what I said earlier about why we have that other circle for the allowed amount, because people are desperate for information about what the in-network amounts are so they can responsibly make decisions of their care. So I mean, it sort of goes without saying. I mean, the complexities of the healthcare system and the interdependencies, when I think about it, it always reminds me when I went out to Colorado, when we went out with a naturalist on a hike, and they explained that in aspen forest, while it looks like it's just individual trees above ground, it's a whole root system that's all connected. And people don't really recognize that, and sometimes in the healthcare system, there really needs to be a sensitivity for those interdependencies, because if you tug here, and something can unravel over there. So we're really thrilled that data now is being recognized as a way to possibly light the way to some smart decisions so that people recognize what the consequences might be of going in one direction versus another. Again, it's not Fair Health's role to say which direction to go in, but it is our role to make the data actionable. As mentioned on the panel, there is an appetite for data. It's important. Really we should take the guesswork out of healthcare reform. It's clear that it's reaching a crescendo of a need to act, and any way in which we can support any stakeholder in the healthcare system, giving them the tools they need, we are happy to really serve in that role. So thank you. Happy to take any questions. Yes.
I apologize for my impatience. Rob Green, formerly of United Healthcare and Dartmouth-Hitchcock Health System. Thank you, that was great. Given the importance of substance use and mental health in both the costs and outcomes, and also the patchwork of state privacy laws, federal privacy laws like 42 CFR Section 2, and carve-outs for mental health and substance use, how do you assure data completeness? How complete is your data in that regard?
No, that's a great question. So we're not getting the clinical claims, so we're getting the administrative claims, but I think everyone who has worked with claims recognize that those claims tell a story. And so what we do is, of our 150 million lives, that's sort of our population data set, approximately 70 million are longitudinal, and we can track them year over year. So we can both look at a population-based clinical condition and look at how much money is being spent globally, say on substance abuse. Then we could take individual patients and track them almost like a SEAL cam on their head, like through the healthcare system, seeing where they're going, what tests are being rendered, and be able to see to what extent someone, for example, who may have been in group therapy, we see 3 months later they are now presenting in an emergency room with an overdose. So that type of information, again, there's no one perfect data set, but there are certain really more than clues. There clearly are dots that can be connected in the claims that we have that could help inform maybe some really interesting decisions about how to move forward with different kinds of therapeutic protocols. Yeah, in the back.
Thank you very much. Just as a matter of disclosure, I used to be medical director of Thomson Reuters, left them in 2011, I guess. And as you know, they in this kind of general space. So as you know, and as everybody in this room knows, and I'm a physician, obviously, claims data, excuse me, has got a very bad name for being inaccurate and not usable. And your presentation today, as many others have, puts a lie to that contention. I've said to many of my physician colleagues when they tell me that can't use claims data for this and for that, I say, well, maybe you are right, that it is inaccurate and not usable. Therefore, we should stop using it for reimbursement purposes and find some other system. And I've actually said that. So I'm a big fan of claims data for all sorts of reasons, not the least of which it's available. In contrast to what we thought was going to be available, I don't remember when, about a decade ago, that we were going to have all this robust clinical data in large databases. So I would just suggest to both Alan and Bobby, this is a really important issue. It's a fundamental infrastructure question of what is needed to deal with the question that is on the table. We need data. And here we've got data, as imperfect as it is, and I'm a fan of it. So thank you for your presentation, and I just think you guys ought to showcase some of the stuff more openly, because the data is there and it can be used.
Sure. In the back? I guess there are two in the back.
Hi there. Andrei Ostrovsky here. Used to help run the National Medicaid program as a chief medical officer, now an investor at Social Innovation Ventures, and spend a lot of my time in the behavioral health space. I'm incredibly excited with what you're doing, to echo the last gentleman's comments. I'm also terrified of the third or fourth slide that showed all your partners, especially the White House in the middle, and that you're sharing data with them, especially in the domain of behavioral health. Can you tell me, what are you doing to make sure that federal agencies, especially the White House, is not getting access to highly sensitive substance use disorder utilization data? And how do other agencies, ICE, et cetera, not get access to information, let's say, on immigration status, things that can preclude access to care?
No, that is a great question, and it also it helps us because maybe we should tweak that slide. That slide is not meant to show our data just gets scooped out to all of those stakeholders. What it's meant to show is Fair Health is uniquely situated in the healthcare ecosystem, neutral and unbiased. We hear from all parties about different pain points they're having, different inquiries or really questions they have. The reason why we have so much data is because we have been such great stewards, prudent stewards of the data that has been entrusted to us, both by our commercial insurers as well as by the federal government through the CMS program. So any data, there are so many layers in there. We aggregate data, it's de-identified, and it's not like people have access to the entire data set. We try to be very pinpointed in terms of targeting what issue they have. Obviously, against the backdrop of any laws and regulations and privacy rules, we're fully HIPAA compliant. So again, if that suggested that we were, offering out, data in the playground to all our friends there, that's definitely not the case.
Thank you. Len Lichtenfeld, I'm Chief Medical Officer for the American Cancer Society, and also agree with what Lou said. Really appreciate your presentation and the information you've shared with us today. Heard a presentation, and I may have gotten it wrong, but I heard a presentation from Colorado a couple of weeks ago where they apparently put a state mandate in place to accumulate similar types of information, perhaps not exactly the same. And one of the questions that certainly came up, having been around the space for a while, was, are we going to end up with a de facto payment schedule for services based on robust data such as you're providing? Clearly, I think some of the clinicians, some of the provider systems are potentially concerned about that. And I know that there's certainly out-of-network folks that you've been involved with Fair Health, where your data sets have been used to help adjudicate claims. So I guess my question to you is, do you see that happening, again, de facto, as data driving a reasonable reimbursement level that includes all the negotiated rates and everything else, which people obviously have a proprietary interest in protecting?
Right. So that's an excellent question, although a complex one, because there are many different types of fee schedules and the way in which the data are being used. So again, sometimes people think there's a Fair Health price or data point for a particular service in a particular area. What we offer, think of it as a dictionary with a lot of different percentiles. When we offer our benchmarks to a particular user, they pick what data point meets the needs of their particular plan. Or for example, we work with a lot of states in their workers' comp fee schedules who have worked with the stakeholders in that state. It's not a one-size-fits-all, and they may come up with a prescribed fee schedule based on the data arrayed for services in the different communities. Then it's interesting, it's almost reminiscent of the conversation that happened in the earlier panel about whether there's a mandate or just advisory suggestions with respect to certain services. You're seeing that play out in the surprise billing debate. So for example, New York has a surprise billing law already. They don't have a mandate as to how providers should be reimbursed for surprise out-of-network services. They use a benchmark, they use Fair Health, a single benchmark of Fair Health with some other indicia offered by the provider or plan to help inform the dispute resolution process. So that's not a fee schedule or mandate, but it's a backdrop to the discussion. Connecticut does have a mandate, and they look at 3 different data points, only one of which comes from Fair Health. So it's interesting, it's moving in the surprise billing debate. There's a real juxtaposition between those who think there should not be any type of prescribed fee for a particular service and instead there should only be arbitration. Some think there should be, and vice versa. I think it goes to the early discussion at what point that'll be the top-down conversation, I suppose, which will be interesting for you all to hear. To what extent will fee schedules start rearing their heads in certain areas if it becomes unsustainable, the way in which prices are changing? But Fair Health takes no position on that. Our data are not, necessarily licensed for that. It's just to really inform other policymakers and officials to determine whether there's something that should be done. There's last one? Okay.
Hi, great presentation. My name is Kevin Fahey. I'm a consultant. I formerly worked with AHIP, where I worked for a number of years on claims-based data research projects, mostly on safety and effectiveness, primarily the Vaccine Safety Data Link, the FDA Sentinel, some other things you may have heard of. One question that comes to mind that you have there in you're determining these patterns, do you have the data on what sort of coverage people have at any different point and how that's helping to focus their decision? In other words, if someone is in what we'll call a gold-plated plan and then shifts to something that has a high deductible, are you able to measure that and see changes in behavior that way?
Right, no, that's a great question, and that would really be a wonderful addition. Right now, we don't have enrollment data. What we do have, it'll often be flagged, whether it's PPO or ASO or HMO, those kinds of gradations we do have. But drilling down into more specific benefit designs, I think would probably, as I said, as we hand the baton to others to even take the data further, that would be a really interesting thread.
That can be a big determinant as to how people choose which drugs they're going to take or not take, whatever they're using, depending upon their benefit design.
Yes. Thanks. Oh, I think we have one more. Lenience, very lenient. Yes.
Hi, I'm CJ Rose from Kutztown University. I'm an economics healthcare researcher. One of the things that claims data doesn't provide. Well, first of all, I want to thank you for your website and for all the data. I've been using it for years, so it's been really, really helpful. But one of the things that claims data doesn't include is things like integrative healthcare, yoga, tai chi, Pilates, massage therapy, the things that people do for their health that are not prescribed by doctors and not covered by insurance. Is there any idea in the future of perhaps trying to gather that kind of data as well?
We are always on the search for new data. What we are excited about, and it ties to something that was mentioned earlier about social determinants of health, we are seeing the claims being coded now with different factors that bleed into that discussion, and then we're really looking forward to publishing it or helping others publish in that area. But yes, there are some services that are not covered, which we would get because a claim has been submitted. If someone doesn't realize that it's not covered, it'll be in the pool of data even though there's no coverage. But it'll be interesting, particularly with the opioid crisis, whether pain management, massage therapy, other things we start seeing an evolution to those becoming covered services. And that would be really a fascinating, item to watch. But yes, we would always welcome more. We have, right now we have so much data, and now with the CMS data, we really want to make sure we make that data sensible, actionable, standardized. We have very sophisticated, really state-of-the-art systems that map it so you can compare apples to apples, and want to make sure whatever we do give doesn't obfuscate things more, and in fact can really help illuminate what you're studying. Thank you.
Thank you, Robin. Okay, the good news is we have a great panel. The bad news is we're missing one of our panelists, but we're going to take the two we've got and we'll get the third. The word is shortly, and we'll keep the conversation going. As Mandy and Chris come to the front, let me just say a few words about where we're going. As you heard from Bobby at the outset, there's sort of this bottom-up, top-down. I don't love that term or that way of framing, but I think it's a helpful image. What we're going to want to do, the question is where to leave the empty chair? Is that the question? So what we're going to, what I want to focus on, and the reason we designed it this way, is that top-down sounds very, heavy. But of course, thinking about things systematically and taking system-wide approaches, it's a little friendlier way to say it. The question then is what? It's not just a matter of, oh, we want to spend less. It's how. It's what are the mechanisms, what are the tools, just as you heard mechanisms and tools this morning. So that's, there's some very interesting work going on in North Carolina. Between some combination of Mandy Cohen, who's the Secretary of the North Carolina Department of Health and Human Services, and Patrick Conway, who will be arriving shortly, who's the President and CEO of Blue Cross Blue Shield of North Carolina, you'll get a sense of what that approach is. My longstanding colleague, Chris Koller, the President of the Milbank Memorial Fund, has worked for quite some time with states on their efforts to take a system-wide approach and to set budgets. And so he's going to offer some context and response to North Carolina's way of doing things. And Mandy, are you comfortable just kicking? I'm sure you won't say anything Patrick hasn't heard.
That's right.
So we'll go ahead and get started with you, and then we'll be ready as he comes in. Is that going to work for you? Thanks so much.
Well, good afternoon. Thanks for having us here and for highlighting the work that's going on in North Carolina. I'm going to skip past Patrick's slides and go to my slides, and then we'll move backwards. But why we can be interchangeable and what I think is unique about North Carolina is the payer alignment that we have there. So Medicare was already doing great things. Patrick and I were there a few years ago. Patrick running the Innovation Center as Chief Operating Officer at CMS. Then we're trying to bring that playbook to North Carolina. And so what we are trying to do on the Medicaid side of things, so you have Medicare moving, the commercial space is moving, and now what is Medicaid doing? North Carolina is moving its Medicaid program to managed care. That was a decision that was made before I joined the Cooper administration in 2017. But with that big opportunity, we are the largest state to move to managed care. We said, okay, how do we look around? Oh, here he is. How do we look around the country for the best ways in which we can drive towards value and bring that to North Carolina? So what I'll tell you about is sort of our playbook in 5 minutes or less of how we're trying to do this. But really the vision is to improve the health of North Carolinians through this innovative, whole person-centered, well-coordinated system of care that addresses the medical and non-medical drivers of health. So you'll see that in the presentation. And so just so you know, we're about 2.2 million people. We're going to move 1.6 million of them into managed care starting February 1st of next year. We're going to do that in an integrated benefits package, integrating physical and mental health together. We are a non-expansion state. I will say that is one of the negatives of North Carolina in terms of cost and value. Patrick can talk to you about if we had expansion, what downward pressure that would do to premiums. I will talk about it from the value from the kitchen table for folks who don't have insurance and what that means for their financial exposure, but is a huge blight, frankly, on North Carolina that we don't have expansion. But here's what we're doing despite that. We're trying to promote quality, value, and population health, and we're doing it in sort of a number of ways all at once, which is a lot of work. So one, and you're going to hear this from Patrick, and again, you're going to hear a lot of alignment. Focus on primary care and investing in that. You heard that in the morning. We're doing that here. We're making a huge investment in primary care and specifically in practice-based care management, putting more dollars to have the practices be the ones responsible for coordinating that care. We have a unified quality strategy for alignment of quality measures, so everyone's not measuring different things. We're measuring the same thing, and we want to keep them focused on things that matter to health. I don't want box checking, I want health. And so we also want to focus on total cost of care. Importantly, in Medicaid, which makes it different than other payers, our financing structure and how we raise our money in Medicaid is kind of weird, and the way we pay hospitals, kind of also weird. Right now, we have a huge chunk of money that sits outside of the standard payment system for hospitals called supplemental payments. If you have money sitting outside the system of how you pay hospitals, no one's focused on value. As we move to managed care, it is required by federal rule that we move those supplemental payments into base rates. That really helps us align folks' attention, if you will, onto value as we move through our program. So that was a really big deal. It moves billions of dollars in how we pay our hospitals around as we make these supplemental payment changes. And then the last is that we're going to be requiring our new partners, our new health plans in Medicaid to actually move into value-based payments. And so by the end of the second year of managed care, so if next year, 2020 is the first year, so by the end of 2021, that we want to see at least everyone moving at least 20% of their payments into alternative payment arrangements or 50% of their total medical expenditures. So at least we want to see big improvements, or if you're already on that train, have at least 50% there. The thing that I think North Carolina Medicaid is getting a lot of attention for is this opportunity the federal government is giving us to generate evidence that I think will help us all think about value differently. I think social determinants has been the buzzword of 2018 and 19. Maybe, right, there's a lot of theoretical talk about, oh yeah, food is medicine, or we really need to really think about housing. I think there's been a lot of really good evidence at very small scale saying that we should be investing in some of these things. What we want to do with our Medicaid program is take those evidence-based interventions and take it to scale and really learn about what should we be investing in. Because we're not going to buy a house for everybody. We're not going to pay rent for everybody. We're not going to deliver meals for everybody. So we really need to figure out how do we pair the phenotype of a patient that we think we can actually improve their health while reducing costs with a particular kind of social intervention. The classic example are kids with severe asthma, right? Kids with severe asthma end up in the hospital, and the emergency room in particular, a lot, where it's an expensive place to get care. We talked about it all day, the emergency room. Let's do a housing remediation effort. Let's give them new carpet and an air filter. And we've piloted here in North Carolina, not surprising, when you give a home a new carpet and new air filter, the kids with severe asthma end up in the emergency room less, right? For the cost of less than one emergency room, we can do that housing remediation work. Saving money, kids are well, mom and dad's at work, right? Win-win for health and for cost savings. But what's the carpet intervention for high-risk pregnant moms? Right, so Medicaid pays for half the births in the state of North Carolina. It very much care about high-risk pregnant moms and how much NICU care we're buying. So if we can prevent folks from having low birth weight deliveries and needing NICU care, that's a huge cost savings to the system. But what is the carpet, right? What's the carpet intervention, if you will, for those high-risk pregnant moms? I don't know, and I don't know that our evidence is strong enough to tell us what that is yet, but this is what this pilot is meant to do. We were given authority to use up to $650 million to try to pair these phenotypes of patients. What kind of high-risk pregnant mom with what kinds of mixed interventions does she need to be healthy and also reduce costs? So a lot of this is an evidence generation exercise. I would not say we know the answers going in. We're going to use a lot of the evidence that has been going on around the country, so we're excited about it. And the one other piece that we are doing in North Carolina is investing. You can't just expect to change the payment incentives and not actually work with the delivery system on changing how they deliver care. So if we're saying it's important to care about health, and if we want to use our money to buy health, we actually need to connect our healthcare system and what's going on in our communities and our social supports. And so we're doing this literally with an IT platform called NC Care 360. It is a partnership with a bunch of those folks you see up there, but largely a platform driven by a company called Unite Us that does closed loop referrals between the healthcare system and what's going on in communities. So just like I would refer someone to a cardiologist, I'm a primary care doctor, I refer to a cardiologist, I would refer someone to a food bank and I'd actually get a closed loop referral. Did they make it to the food bank? Did they get the resource they needed? We already have this live in 27 counties. By the end of 2020, it'll be everywhere. I want to thank Patrick and Blue Cross for being the anchor investor in this effort. It is being driven as a public good, really, a shared utility in North Carolina to really drive towards health. So we're pretty excited about that. And then I'm going to turn it back over to Patrick to tell you about their side of things. There you go.
Thanks a lot.
Yeah.
I'm just a small town doctor from Texas, so don't know if I'll be able to cover as much. And I also apparently forgot DC traffic, so I apologize. I'll hit a few highlights, and I know we want to leave plenty of time for discussion. Been in my role, about to start my third year at Blue Cross North Carolina. There are things I miss about CMS. There are also things I don't miss about CMS. One of the things that we've been talking about a lot is can we be a model of what's possible at Blue Cross North Carolina? And started talking about that very early on, and really about how do you improve health and buy health, so lots of alignment here. How do you have affordability, and how do you have best-in-class experience? And how do you do that at scale in a state? And I do think one of the things that is, at least I think, relatively unique in North Carolina, not that I'm biased, is I think we have component parts with Secretary Cohen, Mandy, and others in the state, providers, employers, really an ecosystem to drive change. And I do think it can be generalizable because it's a diverse state. So on proof points, on the affordability side, we've been able to lower premiums in the individual market by over 4% last year, over 5% this year, lowered Medicare Advantage premiums by 31%. Our goal, and I think we'll reach this, is to have $0 premiums everywhere in North Carolina and Blue Cross North Carolina MA next year. And I'll tell you, when I travel around the state, affordability is a key issue for employers and families. On the quality front, we'll heard about drivers of health. We're investing in population health outcomes as well, whether it be early childhood or drivers of health or smoking or other aspects, and really trying to move the population needle. On experience, our net promoter score for most health plans, negative 100 to positive 100, is negative. Ours, when I started, was 8. It is now 28, which is actually like best in class for a health plan. So now the challenge is, could we be like a real consumer company? And I know there's some health plans that are also providers, so they sometimes have a little higher, but for a health plan that's not also a provider, 28 actually is best in class. So what are we doing? One is on value. We will pay for value. So we are going to shift by January over 50% of our payments at least into real two-sided risk arrangements, including two-sided risk, up to 30% floor of total cost of care, aligned with quality experience, total cost of care. In primary care, as you can see on the slide, we're investing in population-based payments to primary care. We want at least 10% or more of our payments going into primary care. We're at 8+% today, and we're going to do that in a population-based way. Once again, paying for quality experience, lower cost for a population. In integrating mental and behavioral health, we're making major investments, including we just announced a partnership where we're building a company called Eleanor, which is outpatient substance use treatment delivery. We're going to have a high-performance network within 6 months where we'd be able to say to any Blue Cross North Carolina customer, for any mental and behavioral health condition, including substance use, in-person or virtual care within a week, preferably within 48 hours, for any serious behavioral health condition within 24 hours. That is not common for a health plan. Not sure if any other health plan in the US meets that goal at the scale that we're talking. We're also investing in drivers of health. Food insecurity is a board-level dashboard for us, meaning it affects my compensation and everybody in the company, and it's for the entire state, not just the people we insure. So obviously we have to partner with the Department of Health and Human Services and others to achieve that. Housing, we're going to invest millions of dollars in affordable housing bonds and look to roll that out soon. And so those are some of the things we're investing in. This is a little bit about us. I won't spend a lot of time. We insure the majority of people in the state, Medicare, Medicaid, almost 100% of the individual market. You know, for most providers, we're often 60 to 70% of their book of business. But once again, important to partner with others in the state. In particular, we're excited about the Medicaid opportunity that Mandy described. You know, we work together. Mandy hit on a lot of this. You know, this is critical, and it's not just us, it's our teams working each and every day. How do we align the data infrastructure? How do we align the goals? How do we align value-based payment? You know, how do we get the details, whether it's NC Cares 360 or other aspects, so the data actually flows the way it needs to? How do we test and learn together in much more rapid cycle? So that's an example of kind of some of the work we're doing. Opioids in North Carolina is a huge issue, just like it is many places. You know, I talked about Eleanor. You know, one of the major attributes is it will be evidence-based, including medication-assisted therapy, including bricks and mortar when needed, substance use treatment capacity, because we need that in North Carolina. You know, this is actually my last slide, so I'll end ahead of schedule. I could like talk for minutes on this slide. You know, you know, I have this slide in a lot of talks. It really is this call to action. So, you know, I loved my time at CMS and trying to drive change at CMMI and across CMS, working with Mandy and Andy and Don Berwick and so many others. You know, what I've loved about Blue Cross North Carolina is we're able to actually move even faster. No offense to the federal government, but when we have, a plan, we can execute on that plan in relatively rapid cycle. And we're testing and learning in a much more rapid environment. But it can't just be us. You need the state and policymakers at the table. Employers, we need employers to really push for value. I can't tell you the number of times I've gone to a big employer, given them the whole spiel, and they're like, yeah, National Payer X gave me another $500,000 back on the admin fee. To the point we're now guaranteeing medical cost and have switched hundreds of thousands of people away from national payers to refocus them on the medical cost as opposed to the administrative cost, which gets to big employers focusing on value and where the money really is, which is in the medical cost. And then, lastly, how do we put these coalitions together where really you can work across a state, make hopefully North Carolina one of the healthiest states in the nation within a generation. And to do that, it's investments across the whole paradigm from early childhood to the elderly population, both directly in the healthcare sector, but very importantly in terms of buying health as well. So thank you very much. Appreciate your time.
Okay, I don't have slides, but everyone else is standing, and if you're going to get a systemic view, you got to stand up, and anyway, and I'm tall, so. First, thanks to Alan and the folks at Health Affairs and the National Pharmaceutical Council for the chance to talk about this stuff. Yeah, bottom up, top down is a little bit arbitrary, but it's a way to get at the issues because it's going to take both. I also want to say, when I'm asked to respond, my job is to put what North Carolina is doing in a little bit of state context for what's happening in other states. But I'm very supportive of the work that Mandy and Patrick are doing. You couldn't get a better example of multi-payer alignment than working off of the same set of slides. That's pretty impressive. And I think they've got the right approach. The systemic approaches demand systemic solutions. And they're focused on this broader definition of health, including commercial insurers. God bless, we could have more insurers who are held accountable for food insecurity across their whole state. And the levers, but staying focused on the economic levers, particularly payment, but also benefit design and quality measures. I want to put out 4 questions for consideration and talk about how North Carolina's work fits in with what other states are doing. And the first is simply, how are we doing? Mandy can tell you how she's doing for Medicaid, and Medicaid in general has done a pretty good job staying in budgets on a per capita basis. Patrick can tell you how he's doing for North Carolina, commercial insured, his folks, as well as his other lines of business. But how are we doing as a community? Particularly on the cost issue, and I think this is really important because I'm looking at these budgets and I think the marginal dollar, which is why we're all here, the marginal dollar in healthcare could be better spent someplace else. You could put it in patients' pockets, you could put it in roads and bridges, you can put it in kids' education. To do that, you need a systemic measure, or as a colleague of mine says, you can't lose weight without a scale. And so we need local scales to measure costs across all payers. Medicare, Medicaid, self-insured, commercial insured, and consumers. The example I point to that is the work in Massachusetts with the Health Policy Commission, where they have really they have defined the system as the whole state, it's all the payers, and they're measuring how they're doing on trends, breaking up by service type, by price and utilization. So that's the first question. The second is, and this is a little bit redundant, but to pay attention to Medicare. Certainly, Patrick knows where Medicare is going, but if states are working on this stuff, and this is what I used to say, I should, by context, I used to say I'm a recovering regulator. I'm an unreconstructed regulator. We need regulation. So, but when I would work with payers and employers, I'd say, you got to pay attention to what Medicare is doing. Clearly, Blue Cross of North Carolina is designing their payment reforms, and so's Medicaid in the context of what Medicare is doing. That alignment might be more formal in terms of agreements in Vermont. Maryland, of course, is the granddaddy, and you've got it in Pennsylvania. Patrick was involved in all those. But sometimes you want to get the payers not only aligned, but actually paying exactly the same way. And that's work that we've actually learned how to do for a while with CMMI. The third question that I want to put out, and this is more a provocative one, is what you're doing is great. What you're doing in Blue Cross and Medicaid, but do we need an overall system constraint? Now, overall system constraint is a polite way of saying global budget. God forbid we could ever have global budgets in the US, in spite of the evidence that it works every place else. So again, back to Massachusetts, they got up to the edge after they put everybody in. They couldn't quite do global budgets, but what they've got is a targeted rate of growth that is paired with this ongoing measurement of how they're doing. They've actually come in under the targeted rate of growth. I was skeptical that that would work. It seems to have changed the conversation in Rhode Island, in Massachusetts. It changes the way that providers talk to one another, providers deal with health plans, the way that the regulators do rate review, and the way that Medicaid looks at it. So think about an overall constraint. In addition to Massachusetts, you have, Maryland has moved towards that. You have it in Vermont for both Medicaid and Medicare. They're currently having a debate about whether they can bump up payments in Medicaid or is that going to bump against their cap. And Oregon's been very good at that. They've been working under a cap using the feds as the bad guys. They point out to the state and say, sorry, I can't raise my rates anymore because we're working under this global cap that we have. And then the final question that I would put out is, I don't see an answer, this came up this morning, for the question, the issue of monopoly providers. And I'll be a little bit provocative. Essentially what Patrick is saying is trust but verify. And I think there needs to be some local oversight because I don't think that moving to value-based payment alone can, and I've experienced this firsthand, in a battle between titans, the sympathy is going to go to the hospitals, even with your gaudy net promoter score. The sympathy goes with the big hospitals. And so I would make the argument for some sort of local oversight around what's going on. It may not be full rate regulation. It's got to be transparency about the rates. It makes no sense that Medicaid and Medicare set rates publicly and the commercials negotiate in private. I worked hard to make those negotiations more transparent so that people knew what was going on. And then you need some sort of local oversight because as great a job as they're doing, Patrick and Mandy are going to move on. And so you need people that are here beyond particular administrations or particular personalities to keep an eye on what's happening in the local community. Oregon's got a health price commission. Vermont has the Green Mountain Healthcare Board. Maryland's got the Health Services Resources Commission. You need local oversight about what's happening. That also raises the issue of ERISA plans and self-insured plans because you've got to get them contributing. Thank heavens, Mandy, you have a local carrier. It is much harder to do this work if you don't have a carrier that is locally based, that's a good partner, that is accountable. And so you need this kind of local oversight to keep an eye on what's happening because what flies in Vermont isn't going to fly in Texas. You wrestled with that for a long time in your previous role. You need that local capacity to do it. So these are some thoughts to offer. I hope, Alan, they met what you wanted and we can have a conversation. Thanks.
Thanks. Okay, I'm going to try to facilitate a conversation, not just ask some questions, but let me take Chris's points as a point of departure. Let's just start with targets. There is no formal target in North Carolina, is there, or is there? Is there or is there?
There's not a state target.
There's not a state target.
And I'll defer to Mandy whether there should be a state target probably or a public-private target. Yeah, I'll say as a company, and it made us nervous, and it's funny, communications, I made communications nervous at CMS some. I make them nervous some in North Carolina. I've said publicly many times for Blue Cross North Carolina, we want rates across all lines of business less than 5% forever, preferably close to zero or negative. I can't, can I guarantee that alone? No. Do I worry about monopoly providers as it was just named? Of course. And there was a big merger that we came out fairly, just clearly, we didn't think the evidence was clear, it would help. I think the models that I was a part of, so I'm not a totally unbiased observer of Maryland, Vermont, and Massachusetts, I think are really interesting to look at. I do think it's actually a good question. Could a state like North Carolina that obviously has a little bit more of a complex political dynamic, could that work in North Carolina? And if so, what would that look like? I think it's a good question to ask.
And then, Chris, you also paired targets. Your first point was about data. And when you think about the other states that are doing this, there's a big investment in data infrastructure. Targets are only useful if you get results in a timely basis. So I wonder if maybe Mandy and Patrick can talk about sort of the timeliness and the transparency of the data, and Chris, you can talk about what kind of infrastructure you really think is necessary for a target to have meaning, because if you report that, I remember when I was talk about being a reconstructed regulator, when I was doing rate setting in Massachusetts 28 years ago, we were on Excel, Lotus 1, 2, 3 spreadsheets, and we were reconciling data like 8 years prior. I think things have come a little ways from there, but let's talk about sort of timeliness and data sources to figure out how we're doing.
Yeah, well, I think data is so critical to get any of these value-based payment arrangements right, to make sure that the major investment we're making in primary care actually pays off. I've been sharing that I really want to learn the lessons of healthcare data and how we did it wrong in terms of siloing that data, and don't do that again for the social determinants data. So we're actually trying to think proactively on the front end, how do we not compete on the social determinants data and make that liquid in a way that allows folks to actually do the right navigation to the right place at the right time for the right kind of services or resources, whether that's medical care or something else. And so building that on the front end is a lot harder than it sounds like. It's interesting, even when we say we have a shared goal of like, let's not compete, and we actually have the other payers in the state say that you bring it right down to the teams and they do what they know, which is silo our data, worry about privacy protections first, and that not thinking about what are the really, really important use cases of making data liquid. Because I think unless you get to data at the point of care that it's actually going to help someone who's sitting right in front of the person, get them the right care in the right place. All the other stuff is just making sure that happens, right? We have to facilitate the data actually helping real people, and then we as the regulators, or we as the folks who may want to set a benchmark, will then just use that data to make sure it's all going well. But I think first and foremost, I want the use cases to facilitate that data being used to actually help people get to the right place, build an evidence base of what are the kinds of things folks need that can actually save costs and improve their health.
So just building on that, then Chris can reflect. I think certainly on the driver's health and social determinants data, agree, and I think we're building it as we're using it, or whatever the analogy is. So I mean, there's a lot of challenges to work through, a lot of complexity. I think the other place where data is key, and was different for Blue Cross North Carolina. Pretty early on, we said if we're going to go in these arrangements with providers, we got to commit. We're going to give them every piece of data and information we have, period, on their attributed population, as timely as we have, which is usually at least a monthly data feed. That was a big change for Blue Cross North Carolina, and it meant a lot to the providers. Vice versa, we asked for clinical data, so we can update risk adjustment, et cetera. We can put that with social data. So you really have a data infrastructure that's shared and useful across the whole population. So that's what we're trying to build and implement.
And I would say, since we are doing top-down, it depends what your definition of a system is. What is the system that we're working on? And if we are about ensuring the health of populations, and we believe the data around and the research around social determinants of health, then I think we got to define the system pretty broadly beyond a payer, whether it's public or private, or certainly beyond a delivery system. And so how do you get feedback to that system? Maybe it's something smaller than the state, it's communities or something like that on a regular basis. I don't necessarily know that it has to be, and Alan, you were sort of getting, I think, towards the capacity, that it has to be in state government, the way that Massachusetts built it, but it does have to be, I think, authoritative and trusted. So if not, it's difficult for any private data that's trying to describe the reality to have complete credibility. So you need some sort of institutional capacity that puts out numbers that people believe in.
So I'm struck in all three of your answers, the focus was very much on clinical care and decision-making and the like. When we think about budgeting, it's more rolling up the dollars. How much are we spending? How fast are we growing? Who's spending what? A little bit back to to Robin's presentation at lunch about how are care patterns changing. So let me push you in a slightly different direction, which is if you want to be held accountable, or if you want to have targets, even if they're not, embodied in a state statute, how do you know how you're doing? Rate setting is prospective. So how do we, as a system, or how do you think as a state about growth rates or spending levels at the aggregated level, not at the point of care level? Is that even on people's minds?
So, well, I'll say from the Medicaid side, no.
Okay.
Because frankly, we're the worst payer in the market. I think we're already doing a pretty efficient job at how we pay. I'm not actually looking to squeeze that much more necessarily out of our budget. I am wanting to make sure that folks are actually utilizing care, like primary care and prevention, the preventative care, and so we're doing a big focus on making sure that is utilized. But we have the ability to have transparent pricing and a rate and a fee schedule, and so I think I'm interested where Patrick is on that. But I'm actually, of all of the things that I care about in cost, I think I am more interested in making sure that folks are driving towards things that actually make them healthier. So I'm not interested in that unnecessary back surgery we heard about this morning, right? I'm interested in folks making sure that they can, that they have skills that allow them to be employable, so that they can pay their rent and buy themselves food, right? And so, and that is not a Medicaid issue. Those are folks with commercial insurance issue, right? And so I think that's what we're focused on.
Yeah, so I'd say a couple things. One, when we were at Medicare, I believe for the first time ever, we started more real-time analysis of the Medicare data, which led to policy interventions, including one I'm thinking of, an outpatient that was billions of dollars of savings, that was identified through our actuary doing monthly analyses. At Blue Cross North Carolina, we do a similar structure where we're analyzing all the data across all populations, figuring out where there are cost blooms, if you will, both from a patient, a condition, et cetera, and we intervene. And we do that from a target market price perspective, which is the global, for us, setting process. The next thing we're doing, which we actually want to get this published, but I'll give you the high version. We actually said, we also want to measure it to an individual and family. So we were doing something called the affordability index, where we literally took, our 4 million people, we know what they spend on premiums and out-of-pocket cost. You can know people's family income. In case you didn't know this, you can purchase it on everybody in America, including everybody in this room. And it's a numerator and a denominator, and you get a number. Greater than 10% is arguably unaffordable, realizing it's not a black-white cut point. Less than 10%, let's call affordable. The curves are amazing. About 25% of our population is unaffordable by that metric. And it varies dramatically by segment, meaning MA versus what our estimates for what Medicaid may be versus ACA and commercial, which we have the data. We did it for us as an employer, which has driven our benefit design changes about how do we make it more affordable across our population, including for lower income employees in our population, because we're a self-insured employer. We're going to show it to employers. And it really gets to this individual family metric, where if I'm spending, and in the curve you see bankruptcies. You see a percent of people that literally shoot above 100. Either their income dropped completely or they had a horrible catastrophic event. That's a bankruptcy in the data. So how do you get to that level of individual family data and start thinking about how you'd intervene at a state, an employer, a community, down to a sort of individual family level?
So, by the way, Patrick, when you're ready to write it, Alan and I'll duke it out. As the publisher of the Millbank Quarterly,
I'll text Rahul.
You can start a bidding war about it between us. Just remember who loves you. So,
just remember who invited you.
Whoever publishes it.
That's right. I want to go back to Alan's question about the priority of having data for feedback on the system and say, absolutely. It was only through an admittedly mediocre data feedback process called rate review in Rhode Island that we could document and build a public case for the amount of premium increases that were being consumed by hospitals and hospital rates. If we did, and that's pretty rudimentary. That's taking what the health plan submitted to us, analyzing it, and putting out there for public consumption to build a case to help the public understand where their cost drivers are going. So you absolutely need that kind of feedback, in addition to the stuff at the consumer level. Because you got, every state cost-cutting effort has started, frankly, with shining a light on how much we spend on hospitals and how little we spend on primary care. And you've got to keep the public focused on them. That's the job of leadership, is to keep people focused on that.
So I got excited because I got to tell one story. Sorry, Mandy, you may have heard this before, and I will not name the health system. But we were negotiating Blue Premier with the health system, got all the value-based done. We always do the underlying rates last. And so the CEO came in, he's like, really happy about the value-based, I've got a hole for Medicare and Medicaid, so, I need 7% every year. And I'm like, okay, let's do the math on that. And I'm like, that is $250 million. And we cannot do that because we're a not-for-profit health plan that will literally take the money from the individuals and businesses in your community, transfer through us to you, X health system. He was like, geez, is that really how it works? And I'm like, that's exactly how it works. And to his credit, he was like, can you talk to my board? I get on the call with his board, and literally they're like, no, you would take it from somewhere else in North Carolina. And no, I'm like, no. Like, this is exactly how insurance works. Like, if we give you that rate, it'll be $250 million. Here's the math, transferred through us from you. Because the board is like CEOs of businesses in that community. I'm like, this is exactly how it works.
Right.
To their credit, they actually it got them to a lower rate. But I think some of this is like the public doesn't actually understand it. So whether it's at a state or a community level, like really getting into the nitty gritty. And I tell that story because it's illustrative. I mean, this is like the boards of a health system that suddenly are like, wow, that's really interesting. It is actually my money. And you're like, it is. It's your money you're spending.
The CEO understood your argument and needed your help to convince the board.
He did, which is also interesting.
Right. Yeah.
Sorry.
Okay, that's a good story. I think it's worth hearing twice.
Well, and I will also say that similar, I'll tell another hospital story from North Carolina, right, about value-based payment. So there's a lot of folks who like to say value, right? We want to move to value. I'm so excited to move to value, and then you put a contract in front of them, and they're like, oh, wow, that's what you meant.
What's the concept?
And so, but there's always the phone call to say like, well, I want to do that. And so in the context of my putting supplemental payments into base rates, I said, this is the way that you all are going to be able to benchmark for real and move to value. And they said, can you get on the phone with my board?
Yeah.
It's very interesting. I'm hearing a trend.
Yeah,
here.
and there was actually reference this morning to boards.
Yeah.
Can I tell one more story? I know you want to.
As long as it's as good as the last.
I used to work at a hospital, so I still do, actually. There was a different hospital CEO that was literally Rahul's our CMO. He's like, I've talked to this guy like 4 times, and like every time he's like, I love fee for service. I'm not doing Blue Premier. So I go to the meeting and we give the whole spiel about Blue Premier, value-based care, and he's like, I hear you. I love fee for service. I'm not doing it. And so I said, okay, well I appreciate that. So I was like, look me in the eyes. You will never ever get a fee for service rate increase again as long as I'm here. I'm considering cutting you out of network. I've looked, I can buy land right outside your hospital and build primary care. Do you want to think about that some more? So he left with his CFO, about 2 minutes, came back in and he said, tell me more about this. And it's not about being rude or mean. I mean, it really isn't. I mean, that's not it is, we are trying, the way I look at it is we represent 4 million people that we're trying to buy better health outcomes at lower cost. And that's what they want, clearly. And so, we can't pay anyone, including this hospital, rates that lead to the system that becomes unaffordable and isn't tied to value. So anyway, hopefully that's helpful.
Okay, so I want to push a little bit on the value side. And Patrick, I certainly don't want to take on, CMMI at this point, but as a publisher,
I'm not there anymore. You can't.
That's right, but
it all went downhill. That was a joke.
It's not the same. It's not the
same. As a publisher of Health Affairs, we get a lot of papers on a lot of things that came out of CMMI, and by and large, the results are pretty modest if you're talking about savings. And so I appreciate that both of you are pushing beyond just the words. It's not just value, it's what does it really mean? What's the structure? Where do the dollars go? How do you modify your base rates? But what are you really asking folks to do, given that at least from the national data that we have, it's not like there's a magic transformation from the old bad fee-for-service that was overpaying to the value models which are saving enough money to, solve all of these problems? Help me with the translation.
Do you want? I mean, I can start, but I don't want to, since it's sort of a CMI question. I think we've learned some things. We'll be interested in others' thoughts along the way. So I think, and what are the component parts? So I think we've learned about sort of level of risk matters. And I think in a lot of the CMI models, the level of risk may not have been truly high enough. Two, with CMI, and there's lots of reasons for this, the design was never exactly what you would want. So I probably would have done more randomization, more mandatory. I'm looking, but it's, it wasn't always what we could do. So we've tried to have a higher level of risk. On average, in APMs, physician-led, a little better than health system performance, a little better than hospital. Time in the model matters. The good news is I think you have people moving farther along now. I think sort of holistic approach really matters, meaning that you're not just taking a small piece of the system, you're really focusing on total cost of care, quality, and experience. But it's a fair point. I think, it remains to be seen in North Carolina and nationally, how much can we bend the cost curve through all these value-based efforts. I said this morning on a panel more around the pharmaceutical drug space with Scott Gottlieb and Mark McClellan. But I think the challenge is the alternative is worse.
Right.
The alternative is dramatic policy cuts that will hurt people or dramatic tax increases. And so I think this pathway is the best pathway that we need to test and learn on in a rapid fashion.
So I'd say the value-based care necessary but not sufficient. That's the lesson that we got. That we have maybe given it too big a set of expectations and kind of oversold it as a silver bullet. I say that with respect, but the alternative of Medicare paying a fee-for-service, I mean, from the state, I was in the state when you were doing this work, it's like, my goodness, the largest payer is throwing out a template. Health plans, go follow them. So it definitely changes the dynamic. I don't think it is an excuse for hard conversations that I think involve overall budget constraints to force some trade-off issues. You can't guarantee, not only does value-based care, even when it's done well, value-based care doesn't necessarily deliver to its expectations. And there's still a lot of chance that those with economic power, even when they sign your contract, don't necessarily change, even with the risk. I want to make sure the money's getting to primary care, and I'm not going to, we got to trust but verify. We can't just kind of assume it's going to happen.
Okay. So I'm going to try to wrap this together and then get a few minutes for the audience. But Patrick, I have to ask, when you say you brought premiums down, is that from prices? Is it from utilization? You obviously know. I don't know if you can say, but
it's prices and
utilization. It's both.
It's both.
Okay.
And probably a mix of risk. It was in the individual
prices,
market.
risk. Yeah, it's individual and Medicare, and actually much of our commercial market. Right. Price, utilization. I will say there's one area that we have not got under control yet, and it's our pharmaceutical cost.
So I guess I want to pull this together by asking, it is, I loved, Chris, your comment that, you can't do better alignment than shared slides. I am struck that despite the high level of alignment between you, Mandy, and you, Patrick, the focus does actually seem to be in somewhat different places. And that's because you've got different populations. And so, I heard a lot about social determinants of health and primary care investment and base rates. And Patrick, I hear about, changing payment models and value and sort of driving hard bargains. And Andy, as you pointed out, you're in a different place, which reflects where you are and the people you serve. So I guess my question is, I come into this thinking alignment is essential, and the two of you with a history, and Patrick with your large market share, which is not totally unique to North Carolina, but it's a relative outlier. But it seems almost like the alignment is really around concept and maybe making investments in the social side and primary care, but not necessarily in beyond that. And I don't mean to minimize it. I'm trying to figure out, because alignment is hard to do. And so I guess my question to both of you is, how closely do you really feel like you have to be aligned to pull this off? Or am I onto something that you need some alignment, but then there's a fair amount of room for taking it your own direction?
So I would say there's more alignment than you mentioned, because I think our quality metrics alignment and the data sharing is really critical. And I do think that the shared market signal is really important. So if we're saying like, I care about health, and we say that
I care about health too.
Right, but if we both say that consistently all the time, I mean, you actually see people doing things differently. And the kinds of things that we're asking folks to invest in and do differently, I think do require true capital investments. And so when all of your payers are saying, make those capital investments, we're going to partner with you to make those investments, we will pay for some of those investments, and then we can use it as a shared utility, if you will, across all of those payers. I do think that really does matter, even if we start from different places, which is I have a fee schedule, and we just have different types of incentive structures, and I have different ways of negotiating for my pharmacy spend than commercial space. So, but I do think that it is, you're saying it is actually really unusual to even be this aligned. Could we be more? Sure. I think that's why you hear folks saying we should have one payer do this all thing, right? That's the ultimate alignment. I don't think we need to go all the way there. I think there are ways that we can do this within the current structure that we have. We don't have to blow up the things that work in order to make the improvements and the things that don't.
Yeah, just briefly, I tried to hit on some different points just so we didn't sound like the same speech. But I think we're very aligned on drivers of health, on data, on payment models, on what we're trying to shift, how we're trying to work to shift the state. And, combined, we're 70% of the state's population. So I think that is significant alignment that the hope is drives change in the state.
Fair enough. Do you want to add something? Okay, let's get a few questions in from you all. I'm going to try to get some hands that have not been raised so far, which is most of the hands I've seen up before. So let's go over here. Actually, I'll take two at this table, and as the microphone comes.
Dr. Sean Griffin, I'm from URAC. I happen to live in North Carolina until I moved to DC recently. How do we make sure that North Carolina is not the Galapagos Islands, that is its own environment where strange things happen and amazing beasts grow, but it actually spreads to the rest of the continent, and that we can translate your success?
Yeah. Well, so in the Medicaid space, I will tell you, not a week goes by that we are not on the phone with some other state saying, here, we're about like 2 months, I feel like, ahead of other folks, but helping teach others as we move along, and we've already learned some lessons where we did some things wrong already that we can help others not lose the time that we might have. So I think others are already looking at what we're doing. Oh, you're doing this managed care procurement. How did you build in some of these value-based purchasing requirements? How did you build in the social determinants requirements into your procurement? They're replicating that, so it's great. I thank Milbank for facilitating a lot of that shared learning. So literally every week my team is on the phone with others trying to help, and frankly we're on the phone with others, right? Some of them are exclusively doing the integration of physical and behavioral health. That's not new to North Carolina. I stole it from Arizona. The move to value-based payment, Massachusetts is way ahead of where we are. I'm just trying to catch up and learn. You heard about global budgets in other states. So there's other really good stuff going on around the country. I think that we are just trying to learn from that and bring it all to North Carolina all at once. And I think you're going to see states pick and choose depending on where they are in a procurement cycle or what have you, and bring some of those components in as their situation allows.
Yeah, and I'll say two things quickly, because I'm sure you want to get to a lot of questions. I think one, we announced this proposed strategic affiliation with Cambia, so all the Blues in the Pacific Northwest. And I think we think we can drive better health outcomes and a lower cost faster through innovation, scale, innovate, and pass it on to our customers. Two, on the Blues system, I and other CEOs are really pushing the Blues system, which is over 105 million Americans. How do we operate more as a system, learn from each other faster?
Yeah, hi there. Dan Leonard with the National Pharmaceutical Council. And thanks to Health Affairs for putting this event on with us today. And thank you, Dr. Conway, and everybody on the panel. And it's been a good conversation today, and it's been much broader than the topic of pharmaceuticals. And you just brought it up, a comment Patrick, that I actually appreciate your candidness, and I'd like you to draw that out a little bit because our industry is very interested in value-based payment structures and risk sharing. So I would really love your opinion on why it's not working.
Yeah, and I should, thanks for the question, because we are doing some value-based and outcome-based arrangements now with members of your industry. And so and some of those are working well. What I said this morning that I'll say here is, I think we might have a how do you scale this challenge? So they don't become one-offs that are interesting and okay, but how would you actually have a more systematic value-based payment system, if you will, for pharmaceuticals, diagnostics, biologics, new genetic, I'll make it even broader. I do think there's an opportunity there, and I do think it's another good example where if we don't figure it out together, you could get a legislative or administrative solution that is much blunter. And so I appreciate your industry's interest, and I don't think we're there yet, though. I was just quoting what is the reality of our cost numbers right now, as specialty drugs are the biggest mover for us right now. So how do we solve that specialty new biologic issue and pay for value?
Back here, and trying to not be center biased.
Hi, I'm Harry Gawanter. I'm a pediatrician, pediatric rheumatologist in Richmond, Virginia, and I guess I'd like to know how you square what you're talking about with promoting primary care with our previous speaker who showed that retail clinics and freestanding emergency rooms get actually paid, not necessarily charged, but get paid more than a primary care doctor in their own office. And the disincentives that exist to drive people towards those alternate sources of care instead of when we know medical homes, especially for chronic illness, which is growing by leaps and bounds, does better, and you get more value when you are staying with the same people. And how are you addressing that in North Carolina?
Well, I'll start. So first of all, we're paying more for you to be open more. Right, literally, so you can have access like some of these urgent care clinics are, and right, it's a convenience issue. I'll say I use it for my family from a convenience thing. If my pediatrician office is closed, you go to the urgent care, and right, so we are willing to pay more in Medicaid to have those extended office hours. I would rather bring my kids to see their pediatrician if the office was open and available, and so we are trying to make sure that we are paying folks to allow them to have their practices open. We know it takes more money and resources to primary care in order to meet that market demand, and so at least we want to invest in primary care so that they can raise up. Now, we don't pay more in Medicaid to urgent care either.
Yeah, and we're similar. We'll right-size the underlying fee schedule, and we're investing in primary care through per member per month payments. So I think I fundamentally think you have to invest in primary care if you want a higher performing health system, and I think there's evidence to support that.
And this is like home run for me. I've sort of tried to build a career around investing in primary care. I think that there's a market failure out there that doesn't reward high value primary care. I don't think we can wait for value-based contracting to do it. I've appreciated in particular Patrick's statements, for instance, around the value of Blue Cross and Blue Shield North Carolina, but we're actually working to measure what we call primary care spend, the portion of dollars that go to primary care, on a state basis and by payer. We've produced reports with the Patient-Centered Primary Care Collaborative. There are about 6 states that have passed laws to measure and to increase the portion of dollars that go to primary care. It frankly is really politically a great issue because it's bipartisan, and it creates, it creates a base that the hospitals can't assail because the evidence around primary care is really good. And we are agnostic about what kind of primary care. One, we don't think the regulators or legislators should pick it. For my 24-year-old daughter, she needs urgent care. It works well. But for me, I don't go any near it. And we think the patients are smart enough to choose that.
One more I think we can fit in. Let's take in the back.
Hi, I'm going to piggyback off the primary care, Molly McGarrick. Thank you to you all with the state of Delaware, and we've, I think, cherry-picked different things that you all have done over the years as inspiration. In terms of supporting independent primary care practices and moving to value, any state-based strategies around investments or things that we can do, because obviously for an independent, onesie-twosie practice, for them to get the technology platforms, the care management, the adjunct staff, to be able to take on value-based payment arrangements is daunting, and we consistently hear that as a barrier for our docs and other clinicians in the primary care space.
Start, others may. So we did two things. We have a very similar sort of advanced primary care medical home aspect, and then we put partners that they get to choose. Our biggest partner is actually Adaeze. That's where I was right before this. They choose whether they want to partner with Adaeze, but then Adaeze pools them together, bears the risk, provides data analytics, technology capabilities, et cetera. But if they want to partner with CCNC or any other entity in North Carolina, we then have an enhanced fee schedule, a per member per month payment that's tied to quality, cost, and experience, and goes up or down based on performance. And as Chris alluded to, we are measuring percent of dollars into primary care and are heading towards 10%, and our goal is to get above 10% going into primary care. And independent primary care is, the major focus of that.
Yeah, we want to keep independent docs independent, but I also don't think in the complexity of the world that exists that the really small practices are going to be able to do it by themselves. So they really are going to have to think about joining clinically integrated networks. That does not mean you need to get bought by a health system. And so we're really trying to help make matches where folks can say that there are other options. I think there was a lot of binary thinking of like, I have to be a 1 or 2 person doc, or I have to be bought by a health system, and trying to help them understand there's a range of different options and Patrick has been great at bringing other partners into North Carolina to say, hey, there are a range of options. And now I feel like we have a pretty competitive market in the clinically integrated network space, but you need a partner that's going to help you on the data side and then the infrastructure of what it takes to really do good care coordination and all of the things that good primary care looks like. And to allow doctors to actually just like take care of patients, but put that infrastructure around them. So again, we're putting more money into the system saying like that's important and we're willing to pay for it.
And in the states that we work with at the Milbank Fund, I'm not sure this is relevant for Delaware, we hear about this sort of work actually as a rural health strategy. When you're trying to develop a sustainable rural health delivery system, build it on a strong primary care infrastructure rather than say we have to keep our critical access hospital open.
That's a great point.
Okay, so I'm going to channel Bobby here. He had a little ballot at the end of his session, so I guess I have to do the same, which is the question of whether those of you who've been listening today see a role for a system-wide or top-down approach if we're serious about cost containment. You want to hold up your hand so we can see this? And now, it's not a lot. It's interesting. So now that you've had both, I think the real question is somewhere pivoting between 50% of where the impetus for real cost containment needs to come from is whether you're leaning more heavily to system-wide approaches or leaning more heavily to point of care and bottom-up design. You will not be held to account for your results, but I am curious. If you think that the solution to the cost problem depends more heavily on a top-down system-wide budget setting approach, why don't you raise your hand and we'll look around the room. And if you think it depends more on a point of service-wise purchasing at the point of care, bottom-up approach, let's see your hand. And too many of you are still eating lunch to hold up your hand, but that's interesting. Okay, well.
Well, maybe some of both.
Right? No, I was just trying to
asking
put
for the majority.
At 50, right. Yeah. So I was trying to. So all the rest of you are exactly. That's a very crowded point. Listen, I just want to say thanks to all three of you are busy, but I'm going to particularly call out Mandy. Having been a state health officer, and Patrick, you have a large, complex organization. For you to take the time to come up from North Carolina to give this audience a sense of what you're doing is a gift. I hope you all appreciate. Chris, don't get me wrong, I'm glad you came down from New York, but it's not quite as heavy a lift. And so anyway, please join me in thanking our terrific panelists. So with that foot in my mouth, I'm going to move straight. Yeah, I know. That's my dig for trying to poach that article from us. We are going to move directly to our final panel. I don't think you want to miss it. We knew if we put in a break, a few too many of you would head for the door, but you're going to appreciate this conversation. And so I'm just going to move directly into introducing our panelists. Immediately to my left, Jim Capretta, a member of our editorial board, resident fellow, Milton Friedman Chair at the American Enterprise Institute. Seated to his left, Ceci Connolly, President and CEO of the Association of Community Health Plans. And just getting seated now, Adaeze Enekwechi, the President of Impact International. What we've asked them to do is to give some thoughts about how we move forward on the cost issue, trying to build in some of the top-down, bottom-up perspective that's shaped the day, but we also know that they are thinkers of their own and don't need to be shoehorned into that structure. So I'm just going to ask them one at a time to take about 5 minutes to give some thoughts. Like with the last panel, I'll ask some questions and then we'll leave some time for the rest of you to come in. But Jim, welcome. You want to get us started?
Okay, will do. Thank you, Alan. Thanks to Health Affairs, thanks to the National Pharmaceutical Council for sponsoring this and for allowing me to be a part of it. It's a very interesting conversation I got to listen to prior to ours. Hope we can match it in terms of quality. I'm sure the others can. I'm not sure about me. We'll see. Look, this last poll that Alan just had of all of you, do you lean more toward a top-down systemic solution or a bottom-up solution? And here, I think one distinction that needs to be made, which is that it seems obvious to me that something systematic needs to happen here. Now, that doesn't necessarily mean that it's a global budget a la, the UK and Canada and many other nationalized systems. But there's something going on in federal policy, if that's what we mean by the top, that permeates the entire system. And of course, Medicare is a dominant player in the health system. If you want to know the number one reason why our system is organized the way it is, there are a lot of factors involved, but the number one factor is certainly Medicare's structure and incentive system. So to the extent that we're talking about systematic top-down things, certainly Medicare and how does Medicare interplay with the rest of the system would be at the top of the list. So I think making that distinction is important because from my perspective, when one thinks about cost control and getting our system under more discipline, really what the question we're really looking at is how to make the underlying delivery system more productive. We don't usually phrase it that way, but essentially, if you think about other sectors in our economy, they become ever more productive over time through competitive pressure. That's really what drives them to get better every year. If they don't get better, they lose market share to their competitors who do get better. And so if you don't do it through a competitive approach, you have to then assume through a regulatory top-down, just we need to control it approach, can somehow make our system more productive over time. And it's not a natural follow that regulation leads to higher productivity. It could happen. That's why there's this emphasis on value-based payments. But it's not natural that it follows that. In fact, very often, a top-down regulatory approach can lead to less productivity. And how does that manifest itself? It manifests itself in essentially supply being reduced, which may be a good thing in our health system because it may be overbuilt, but that doesn't necessarily make it more productive at the patient clinical level. Okay? So I think there should be some caution when one says, okay, it's either top down or bottom up. Well, if it's top down in a way that is just a global budget that sort of says we're going to pay Medicare rates to everybody, and believe me, the path of least resistance in the United States is that path. Okay? If you think they'll come up with some refined way of doing this on the Hill, when they're working with CBO on cost estimates, and we're going to have this value-based nirvana driven by a global budget set by the Congress, That's not how it works. They'll set a global budget and they'll say to CBO, how do we make this work? And they say, well, the only way you can make it work is extend Medicare rates to everybody. If you think that's not the way it would work, I really think you haven't watched what goes on. So be careful about the top-down solution if you don't like the implementation that would follow. But that's not to say that we don't need something from the top. Like I said, federal policy is driving a lot of what happens. I love what I hear about value-based payments all throughout the country. You hear lots of stories about people working on all kinds of things. But when you get in closed rooms and you talk to people that are delivering care in their big medical systems, they say things haven't changed that much. They changed in a little bit. I think Alan's point about all these evaluations of what's going on and the modest results so far, take that to heart. Things are moving a little bit in the right direction, but there's no revolution going on. Okay, so there's something systematic that needs to be fixed, and I don't want to fix it necessarily with a global budget, but I do think we need to change federal policy. From my perspective, obviously, Alan introduced me as the Milton Friedman Chair. I have to represent the free market way of doing this, right? So, I believe we ought to do this in a way that brings more competitive pressure to the system on a number of dimensions, and because I have 6 seconds left, I'm not going to tell you what those are yet. So anyway, that's just to get us started. Thank you.
That's terrific. Thanks. Ceci.
Well, let me start by saying thanks to Alan, Health Affairs, NPC for hosting, all of you for staying for this entire session. We appreciate it. I agree very much with Jim and what he's just laid out. When I was asked to do this session, I was reminded of an experience back from my reporting days in 1996. I was covering the Dole presidential campaign. And in the waning days of the campaign, when it was very clear to Bob Dole and everyone else that he was going to lose, he went on this nonstop, round-the-clock, 96-hour campaigning marathon. And he said over and over again, where is the outrage? Now, in his case, he was outraged about a variety of things. The incumbent president he was running against, the incumbent president's behavior, and frankly, probably why the heck he was losing. But it comes to my mind because where is the outrage about our incredibly overpriced, underperforming, dysfunctional, fragmented, non-system health system in this country? Unfortunately, it is not here in Washington. If there was any shred of genuine outrage over this, we would at least have a Congress that could pass the CREATES Act, right? Talk about like a teeny tiny baby step that they still can't get around to doing. If there was sufficient outrage in the industry, we wouldn't see the level of fee-for-service medicine that we continue to see today, I am sorry to say. I do think, though, that you see the outrage outside of the Beltway, and you see it in all of the polling data and all of the focus groups and employers and individual consumers who have had it with the lack of value that they are getting for their health care dollar. So I would like to see a greater sense of urgency brought to this conversation and action. I actually think that Patrick had the sort of polite pediatrician version of outrage, which is why people like him probably so much more than me. He had his call to action, and I'm looking for the outrage, or I guess Jim's revolution. But I think that there has to be much greater pressure on all of the players. And to the question of top down or bottom up, I'm going to say both, maybe because I've lived in Washington for a long time, so I'm pretty familiar with political double talk. But in this instance, I think that we do absolutely need to have both happening simultaneously. There's not going to be any one single answer to this problem in our country, but let me just tick off a couple of big categories, and then perhaps we can get into some of those throughout the conversation, Alan. But some of my big sort of targets: low value, inappropriate care, waste, pick your term of art. The estimates are somewhere from $200 billion to $340 billion per year. Lower back surgeries were mentioned earlier. We can all go on and on about the number of procedures that receive an F or a D from the preventive task forces, and yet they're done over and over again. So we've got to get clinicians to stop doing them, and purchasers and payers need to stop paying for that stuff. It just is a waste of everybody's time and money, and frankly, in a lot of instances, it can even be harmful and dangerous to the patient. So I would love to see much more effort on that. I do think that the body of academic research for now well over a decade in this country, we have a price problem in the United States. We have a price problem. Whether you want to go and look at the work by Ashish Jha or way back Uwe Reinhardt or any of the other studies in Health Affairs and other prestigious journals, it is obviously acute in the drug space, medical device, hospitals, but it's across the board. We've got to do much more just on straight up pricing. I would also say we need to start looking at clinical teams that are not just MDs and not just specialists. There has to be much greater use of physician assistants, social workers, pharmacists, you name it on down the line. And it does have to be done by a clinical team wrapping around the patient, not just high-end specialty all of the time. And then finally, I'm going to come back to my favorite target in all of this, which is fee-for-service medicine. And the simple fact, and I'll tell one more story in my final seconds, when I was a reporter, if my editors had come to me from the Washington Post and said, we are now going to pay you by the word, what do you think would have happened to my stories? They would not have necessarily been better, but they sure would have been longer. Does it mean that I'm a greedy, horrible person? I hope not. I think it simply means that we all behave in the economic paradigms in which we are put. And right now, most of our health industry, physicians, hospitals, drug companies, et cetera, are paid to do things. They are not paid for the outcomes. And those perverse financial incentives are driving way too much bad behavior.
Thank you. It's a perfect segue into my words, and thank you, Alan and Health Affairs, for the invitation to speak here today. I've actually hung around most of the day because Alan instructed us to be here all day and be in a position to summarize and opine on what we've heard. So I listened. And in addition to being ready to talk about what we heard through the day, I have some thoughts I want to share with the group. I think all of us, just to bring this back to the human being element, all of us are confronted with major health decisions with cost implications at some point in our lives. But in truth, when we are confronted with those healthcare issues, whether it's a major illness or an acute episode, that is precisely the point when we are least capable and least equipped to make the best decisions for ourselves or for our loved ones, for those of us who have children or aging parents that we're taking care of. And so during those moments when we are at our most vulnerable, our decisions are usually driven by constraints, whether they are logistical, financial, and economic, or social supports, where you live in the country, or quite frankly, among our aging population, isolation. So you take all of those potential risk factors, put them in a fundamentally disjointed health system, and you find that any one of them can immediately exacerbate an already fragile situation. We're in a market-driven system that prioritizes profits. Incentives are often in conflict with what is best for the patient. And for those of us who've been in government and in the private sector, you find at times that administrators will take what is best for the bottom line and retrofit that into defining what is best for the patient. And in an area where there's no evidence, I'm a health services researcher, we're often talking about what's the evidence for best care. In the absence of evidence, anything is good for the patient, right? If you can just define it as such. So if we're serious about making the most and the best, the best and the most effective decisions, we simply have to tackle prices head on, as Ceci just discussed. We've not been willing to do so to date, and the forces against doing something about prices cannot be overstated. So let's assume we live in a country where we've agreed to do something about prices and how much we pay for healthcare. It means we pay less for services. It means we use less services. We focus on preventive care. We squeeze out administrative costs. We rein in unchecked access to specialists unless an individual or a household has an increased ability to pay. We expand the provider community to include cost-effective non-physician practitioners. And we address social factors that we all know from a century of literature are the larger drivers of health outcomes and cost. So our approach, and when Alan teed up this question at the end of the last session, I raised my hand twice, actually. I don't believe it's an either or. And I think that if our approach to successfully controlling costs will require a consensus about what we believe is of value. It will have to be a joint effort. And I think that will include clinicians, policymakers, individuals, and patients. We will need to get to a place where physicians do not equate the best care with every possible intervention that is available just because the intervention is available. I think clinicians need to be in a position to guide patients towards the best medical as well as wellness options. Cost control will have to include top-down approaches, and that is input from policymakers who have a studied approach and a view of the broader space that can inform the country's path in a different direction. But we usually reject any opportunity to take on costs. We have many examples. I thought that Reed's bringing up PCORI, however you feel about PCORI, is a great example from this morning. I think some of us have scars from the attempt to just discuss a Part B drug demonstration where people dared suggest that perhaps we could pay less for drugs and just to test it. And see how that might shake out at that point, I think 17% of our total health expenditures. I think also individuals themselves have to buy into the notion that more is not necessarily better and that health is much more than access to the most expensive medicines and services. And I'll just close by saying that I'm not sure we will get to the point where healthcare is 10 or 12% of GDP in the US. I don't want to sound pessimistic, but we would have to reverse course in so many areas. And I don't see that happening in a country where we have baked into our DNA, it seems, that unrestricted choice is, by default, the best course of action. So I'll just close there and turn it back over to Alan. Thank you.
This is a great way to open, and there are many different directions I'd like to try to take the conversation. I hear two fairly different pathways, and I want to follow both of them. One of them is just the straight price issue. If you're trying to reduce how much we spend, you could do nothing other than change prices, and that, if they went down, or slow the rate of growth, that would diminish the share. But then I also heard a lot around various aspects of utilization, the incentives of fee for service, understanding what is valuable from the patient's perspective, from the provider's perspective, and increasing the productivity of the healthcare system, which sounds to me like changing how we deliver care, not just the price side. So I want to try to bifurcate this a little bit, although everything is related, but to try to make sure we cover both of those. Let me start with the price side, actually. It is sort of easy to say we're an international outlier, we should pay less. We heard Patrick describe one way of sort of using the market power. Jim, I think a common concern, and I think Adaeze raised it in her first words about at the time of care is when you're not well situated, common concern about sort of expecting competition at the point of care or at the decision maker as the individual is the lack of market power. So if you're thinking of this from the perspective of harnessing market forces and we're trying to get at price, is it individual? Is it Do individuals have to be represented somehow? How do you get the market dynamics to start taking on price?
Yeah. Let me say two things quickly. First is that when we compare prices with here with international pricing, we should be careful a little bit in the sense that, in the United States, first of all, we're a wealthier country than any other country on a per capita basis, so we are going to spend more on healthcare, and a lot of it is related to how much we pay our practitioners. And so the physicians are paid a lot more here than they are elsewhere. I mean, a lot more. And is that always a bad thing? Let's think about that for a second, okay? Because there's signals that are being sent to who gets trained to become a physician, what kind of living they can make when they become a physician. So be careful to just always assume if we're paying more for someone's salary to be an orthopedic surgeon, yeah, they're making a lot of money in the United States, but I'd rather have pretty good orthopedic surgeons, that are well compensated and attracting the best people for that than not, okay? Now, having said that, pricing at the point of service, it's quite true. Not to plug myself, but I just did a paper that kind of tried to look at all of this, and it's quite true that in a lot of instances, you're not going to have price shopping at the point of service. Someone has been diagnosed with something that is contingent on other things happening in the clinical process, like cancer, almost every kind of type of cancer. You start down the road of being treated, and they're not really sure which pathway they're going to follow. And so, you can't really price that in advance. Now, having said that, healthcare being as complex as it is, there's a lot of things that are shoppable. There are lots of elective surgeries. Yeah, you need to get it done, but it's not something you're going to get done tomorrow. It could be something that's done a month from now or 6 weeks from now. And here, we're talking about things that could have clear pricing. My recommendation here is there's two things you got to do if you really want more consumer activity comparing prices. First is you need incredibly rigid standardization. So you got to make everybody price the same thing. If you have a consumer saying, I'm trying to figure out if I need my shoulder repaired, do I go to this surgeon or that surgeon? They need to make sure that they're comparing apples to apples, that the service they get from those two offerings are exactly the same. Okay? Then they can compare the price. So my recommendation, the regulatory solution is I'd make everybody who's offering that service offer that service with the same clinical definition and tell us what price they're going to charge. So standardization is one. The second element is you need people to care about it. Okay? And so, yeah, we have high deductibles, but people blow through those deductibles pretty quickly. So it's not really a deductible question. It's really more a question of if they picked a lower priced option, does the consumer benefit from that? And there we're talking about sort of a system of reference-based payments. So my basic recommendation here is start a definition. And the administration, to their credit, has tiptoed down the road on this. I think they need to be much more aggressive, but start a list of standardized things and make everybody set prices to tell us what price they want to charge. Don't have us tell them what price we want. Make them tell us the price. Okay? And then secondly, make sure everybody cares when they're picking a higher priced option versus a lower priced option. And so if you start to do that, then yeah, not all of healthcare will fall into that, but about half at least will, and probably more. And so I think there is the beginning of how to think about pricing.
Ceci and Adaeze, you both brought up prices too, so keep us going on this path.
Well, a couple thoughts. One, I agree with Jim. I would be thrilled if we were paying the best surgeons in the country the highest salaries. The problem is that we are paying the lousiest, the best, and the average surgeons high salaries. Right? Why are we paying high salaries for the bad stuff, the outliers, the variation, the errors, the poor outcomes? That's my biggest concern around us. Isn't it great to spend more on healthcare? Yeah, absolutely. I mean, if you ask me on my personal budget where I want to spend most of my dollars, it's going to be on the health of me and my family. For sure, absolutely. But I don't want to flush it down the drain, and I don't want to keep going back to the hospital having readmissions and infections because I'm not getting the right care, or because physicians are prescribing things that have adverse events because they haven't looked at, my complete medical record, on and on and on. You sort of get the point here. I'm a simple Pennsylvania girl, and what I'm not seeing is us getting our money's worth. And that's my biggest problem with high prices in this country. I do think that you have to talk often about price and the delivery of care together nowadays. I think we heard from Robin some really exciting data around site of care. We are so excited at ACHP about the promise of telehealth right now. And I know there's still a long ways to go, and it's not going to be for everyone in every situation. But the mental health data point that she put up in particular was really exciting. And not so much from a financial perspective, but from a health perspective. When you think about the problems in our society today and getting relief to people that they would actually be able to access and would access and use, the level of inpatient care delivery in our country today is driving a lot of the costs. And I've posted all sorts of links on my Twitter today for you to see these specific case studies with data points. But for instance, you look at Security in Marshfield in Wisconsin and the work that they're doing right now on home recovery, which by the way, people like a whole lot better than being in an institution. And you are seeing length of stay go way down. You're seeing readmissions go way down, and satisfaction is up above 90%, and it's a big savings. So I'm not usually the rose-colored glasses gal going, ooh, it's a win-win, but that is a place where the delivery of care really does make a difference.
I'll pick up on a couple of points Jim raised. So I think when we talk about physician salaries, and I know we don't want to devolve into that, but since it was raised, if you come out of a subspecialty, musculoskeletal radiology, it's the one that popped in my head as you were talking, you can make $1 million, right? In any number of jobs in the country, just coming out of the residency program. I doubt that if I were to fall and break a leg in France and would need the services of a musculoskeletal radiologist, that somehow the care I get or his or her services would be 5 times worse than what I would get here. As I'm just making up a number. I'm going to assume it's at least 5 times higher in terms of the price of the salary here, at least, maybe 10, but probably not less than 5. It's a lot of money. And so I think I don't want us to what I'm trying to get away from is to take a lot of our current state as a given that is just the way it's supposed to be. I think we're at the point now where we keep saying it's unsustainable to be at close to 18% of GDP, to take everything that we have, that's the reason why we're 18% of GDP as a given. I think we have to start questioning some of these assumptions. So that's one. When I was at MedPAC many years ago, I was leading the work on redesigning the payment system for outpatient therapy services. And I remember that now because lumbago, lower back pain, is one of the most frequent codes, CPT codes for physical therapy. When you're at MedPAC, which is an influential organization, and you talk about redesigning the payment system, alliances will form right before your eyes, coming to talk to you about what you should not do, what you should not touch. So that happened to me. It wasn't personal, I remember, but it was intense. And when you ask these organizations, can you give me, if I can go and get a certain number of therapy units or therapy sessions in a nursing home, there are 10 different sites where you can get physical therapy for that condition and for hundreds of conditions. But the variation, the number of units on, say, a 75-year-old patient who can only take so much therapy in a 24-hour period was so vast, indicating that we have no clinical guidelines, there is no standardization, and there's no one at the helm who, among this narrow group of professionals, is responsible for deciding what we should get or what an average Medicare patient should get. Until we start to kick the tires on the assumption that it's okay to pay per word, right? If we're going back to Ceci's world, that's why we have to address price. If we stop paying whatever you want or whatever you say the value of your service is, per word or per unit, I think we can at least start to have the meaningful conversation, an honest conversation, quite frankly, about why we are where we are.
So let me try to pull in the other side of this, which is delivery. Again, Jim, you started with this notion of competition as a method for increasing productivity, and that's sort of the bottom line economic way of looking at it. I had this question this morning, but Bobby didn't call on me. Thanks. Kidding. But since I knew I was going to be up here, I figured I could ask it later. It's just to a different set of panelists. But I was listening to Elizabeth's stories and about employers making wise decisions, and particularly this notion of cutting back on unnecessary procedures. And it occurred to me that from a systems perspective, not from Walmart as the employer's perspective, but from a health systems perspective, if her employer is able to have it such that the workers at that business don't get that service that was unnecessary, that's a savings to the employer. But it's only a savings to the healthcare sector if that doctor or hospital where the procedure was going to be performed, or the hospital who's going to perform this procedure, doesn't perform it on someone else. Maybe they should be working at Walmart rather than performing this surgery. That's a reference to this morning you have to have followed. So my question is, what's the mechanism for, if we're talking efficiency, if we're talking actual resources, not prices, we're talking efficiency and resources, productivity, what's the mechanism by which, when we have leading employers or purchasers, whether it's individuals making these wise decisions, saying, I'm not going to get this wasteful thing, this is not necessary, how do we actually pull the resources out of the system and put them somewhere else more productive? Because if they just go to a different patient or the hospital fills the bed with someone else, there are no cost savings to the system.
Well, that's one way to look at it, of course, but I guess I wouldn't look at it that way myself. I mean, I think the question is, first of all, I agree we need a systemic solution.
Right.
So it's not like you can just say, well, I'm relying on the smart employers out there to get their act together.
Yeah, and I want to be clear, I wasn't picking on you with the question.
Oh, I thought you were directing this toward me. Okay.
It wasn't intended as such, but
yeah. Well,
anyway.
Let me jump in anyway.
Please.
And when I've gone too far, you can cut me off. So I would say that it could be a systemic solution if that employer was operating under the same economic incentives as the other employer down the street, and the other one, 10 miles away or wherever this physician might try to sell his services unnecessarily to some other patient. If they're all operating under the same incentive that says, hey, look, I got to get this under control because it's coming really out of my pocket and my workers' pockets, sort of as Patrick was indicating at the insurance level, I think then you start to have a systemic solution. Nobody wants to pay for the unnecessary service. Now, what am I talking about at the systemic level, at the federal level? I mean, a lot of employers are under pressure today financially, and they want to get their costs under control. But do remember that about a third of every dollar of an extra premium paid at the employer level is coming out of taxpayers' pockets. It's a federal subsidy, okay? And that has an incentive. Yes, they do want to get costs under control at the employer level, but they don't want to do it so much where they make their employees unhappy, because it's an employee benefit. And if the competitor down the street is going to offer a more open network, I don't necessarily want to offer a more closed network because I have to compete for my workers. So you need all the employers to be operating under the assumption that they got to get their costs under control. Now, this brings me to my favorite issue, which is I think the number one thing that could help in this regard is the one idea that everybody in Washington wants to get rid of, the Cadillac tax. It's the provision in the Affordable Care Act I dislike the least, okay? So let's keep it, all right? It's the one thing that everybody wants to get rid of. Why do they want to get rid of it so desperately? Why are these coalitions forming? Why is everybody lining up to get rid of this thing, this awful thing that might make us change something? It's because it might work, okay? So when everybody starts crying about we need a global budget, we need a top-down solution, these terrible people are ripping us off, and it's et cetera, et cetera, et cetera. And then you've got the Republicans and Democrats lining up like crazy to get rid of the first thing that would actually pinch. I mean, my sympathy level's a little bit low, really. So, wait, that's enough of a rant to get us going.
That's
right?
good. Okay, so I want to be clear why this was not targeted at you, because I think it's really important to hear from the others on this as well. I guess the reason I asked the question was not to sort of challenge the individual purchaser approach, but to ask it more broadly from a systems approach, which is if we're trying to have a more productive system, again, we had prices on one side, we have productivity and resources on the other side. And to the extent that we need part of the solution to come from a more productive system, then we need to redeploy resources. Ceci, you talked about the average or below average surgeon. We need to redeploy resources out of healthcare, away from healthcare, or else somehow they're going to have to be fed by the healthcare dollar. And if we're trying to reduce the number of healthcare dollars, we need to take them out. That is, in many respects, that's a harder thing to do, top down, or harder thing to do through government fiat than to let the market with its sort of creative, destructive capitalism do it. So I think the question, and it's really, again, I just want to be clear why I didn't mean for it to seem like I was picking on you, Jim. I think all of us need to grapple with the question of how do we take resources out of the system that are not as productive as other resources that really are giving us the outcomes we need. And Adaeze, I mean, you commented on needing to have some consensus about what's value. So the corollary is, what's the mechanism for taking the things that aren't producing that value out of the healthcare system?
Even before you called my name, I felt you were picking on me. You've challenged me on this point. At least once, maybe a couple of times, specifically around social determinants of health. If anyone knows my work, that's my research area. I talk about that a lot, and I see it as a healthcare issue. So while from one corner of my mouth, I'm talking about what are we doing about costs, here I am talking about social determinants of health as a healthcare issue, with the necessary implication being resources to address social determinants of health. So if I can just, if that's sort of what you're getting at, I would like to talk about that a little bit. I don't have an answer as to the mechanism. I'm someone who sees, I think I tend to be very practical. Social determinants or social factors that drive health, whether we like it or not, show up in the healthcare system, right? So if you're homeless, we just heard from Mandy and, I was going to say Mandy and Andy because that's who I worked with, but it's actually Mandy and Patrick. We heard them talk about what they're doing in North Carolina. A lot of that is, especially the $650 million commitment from the state, experimenting with ways to address social factors that have not traditionally been considered within the sphere of healthcare. I think what's driving that is the final recognition. This isn't new at all. There are decades of literature and pilots and tests funded by smaller funders that have led us to a place where we now know if we have a large homeless population, people who are food insecure, people who have been obese their whole lives and have had, as a consequence, a whole series of healthcare issues, it shows up in the ED. So we pay for that at this top bottom. We pay for that eventually once they hit the healthcare system, when in fact we could have had more cost-effective, perhaps, ways outside of the healthcare system in the social services arena to address those issues. When we are confronted with them in the healthcare setting, I don't know how to pull that out, because I think at that point it's not a question of, it's an acute issue at that point. And we have to deal with it. And quite frankly, Alan, I've said this to you, if you point me to the sector that is better organized, better resourced, with the types of data that we need, right, to address social factors and some of the other issues we confront in the healthcare system, I'd be happy. I'd be the biggest champion to shift this issue to that space. But I don't think we have that. So as messy as our field is, it's actually the best place. And I think it's just a fact. I was talking to someone from Kaiser, where they are investing $200 million to address homelessness. Kaiser is not a homeless shelter provider. But here they are spending $200 million, and in addition to a whole host of other interventions they're spending money on, because for them it is a crisis when those patients hit their business. So I think we're trying to solve a problem because it's become a problem as opposed to something that we could have prevented if we had, quite frankly, a better distribution of resources. Perhaps that, I know it's a legislative issue, so I don't think it's perhaps. And maybe a more thoughtful approach to how we appropriate dollars for health, for housing, for transportation, et cetera. So I'll stop there, but that's my general take on that question.
I just was going to chime in on a couple
Wait,
of...
I first, did you feel picked on?
No,
Cece, everyone else did. I'm just curious.
Not yet,
Okay.
but there's still time.
I'll work on it.
There's still time. Well, first, I just wanted to clarify, I don't think that any of us expects that healthcare spending in this country is going to go down by 1 penny, right? It's now all about what will the rate of growth be, because at the end of the day, every healthcare dollar spent is a dollar of someone's income, someone's salary, okay? So just think about how difficult that is to start walking up to individuals and companies and saying, we'd like to reduce your pay. So I think we need to be realistic about that. But I do think that much of this does come down to incentives and motivation. And I'll give you, we've been sort of picking on doctors a little bit today, but I think that there are many ways to engage doctors in helping on value decisions, if you will. And it's not even around the give them a tip, so to speak, in a value-based upside bonus program to do the right thing. At Geisinger, our health plan in Central PA, they came up with a very detailed, very proactive treatment for Hep C patients. Very hands-on, not just using the expensive specialists, but lots of other kind of community care folks. Long story short, what they discovered was that they could reduce what was a 12-week protocol down to an 8-week protocol with the same amazing cure rates, 97 to 98%. Well, the message to the physicians became, by following this protocol, which we've now studied very carefully, you can treat 3 patients, not treat, you can cure 3 patients for the price of 2. Now that is messaging that doctors respond to, because why did they get into medicine? Was to help and treat and cure people. So I think, when biosimilars are getting scrutinized right now. Will they really save money? How much will they save? We thought they'd come in at 30% less. They're coming in at 15% less, et cetera, et cetera. But what I can tell you is that when you have physicians participating and talking to their patients about, here's a lower priced alternative therapy that could work very well for you. You'll save some money, the health plan will save, the system will save, everyone. We see uptake at our members when they approach it that way in the high 90s up to Group Health Cooperative just had a 100% conversion rate on one of their biosimilar products. So when I talk about incentives and motivations, it's also appealing to people's reasons why they're in healthcare to begin with, and the good health that we all say we want for our communities and our families.
Yeah, just one thing. Your initial question was, how do we basically get the money out of the health system and pocket it, not to be redirected somewhere else in the health system? And not to harp on this point, but remember that the something like the Cadillac tax was going to save $200 billion, okay? And that's tax money that is essentially going to be coming into the federal treasury to be used to cover all kinds, it could be paid for education or highways or whatever you want, or the deficit, heaven forbid. So that's the kind of thing that would take a huge amount of money out of the system. which is why it's unpopular, okay, in part. And so I think we should understand that there are ideas out there that could do this. They're not just a global budget.
Right. Well, and it's funny, reflecting, now I get to pick on, for evenness, Ceci. You said, and I've sat in rooms like this dozens and dozens of times where we say, you couldn't possibly say to someone, you're going to get paid less next year. We do that all the time in other industries. Yeah. I mean, look at the auto industry, look at my industry of publishing. It's just like we take money out of it all the time. And no, it's not done happily, and no, people don't like it. But it's not as if in the American economy it's unheard of for compensation to go down year after year. It's just that we think this goes back to where Reed started us this morning, which is we think we're special and that we should be immune from that.
Exactly, and I was as much reflecting sort of my years as a political reporter, and that healthcare becomes so personal in this country, and the politics of healthcare get treacherous. But you're absolutely right.
Yeah, it's just interesting because it's so easy to say that, and yet we've all seen it happen elsewhere. We have time for 3 or 4 questions, and then we're going to promise to get you out here at 3 o'clock as planned. So I'll start here and go behind you, and then we'll get a few more in. Wait for the microphone.
Hi, I'm CJ Rhodes again from Kutztown University. I've heard a whole lot of things the whole day, the physician salaries, the hospital prices going up, et cetera, et cetera. What I haven't heard anything about is one of the issues is the extreme amount of administrative costs of our system, which includes our and I loved what you said about standardization, because one of the problems is the non-standardization of EHR systems, which are causing us to spend millions and millions of dollars on information technology, which then has to be redone again and again and again as we get closer and closer to standards, as well as the fact that it used to be 1 or 2 staff person per physician is up to 7 staff people per physician in order to enter all that data, which is wonderful to have the data. At the same time, we're having all this wasted, and one could say wasted administrative costs. Where do you see that in the future? Do you see anybody doing anything about that?
I'd like to start, if I may. I mentioned administrative costs in my little spiel, but I'm so glad you're raising that. When I think about that, you're familiar with the IPPS, the OPPS, inpatient prospective payment system, outpatient, et cetera. So we get it wrong every year. We clearly cannot figure it out because we tweak it every year and we update it every year. And every time you update it, that introduces a whole slew of administrative activities, right, in the industry. Whole consultancies are formed and exist and will continue to form as long as we keep tweaking the payment system. We're layering additional, CMMI and a whole host of other entities in the federal government that introduce new things each time, and that spurs further administrative costs to clinicians, to practices, et cetera. I don't see that stopping anytime soon because we're still not really having a frank conversation around stripping all of that out and what do we want and how might that work. We're just not there. Global budget, we have one in Maryland. Who can explain that? Who can explain the Maryland global payment system and global budget? Like 2 people in the state of Maryland. So it's not like, and that is supposed to be a simplified approach. I'm actually not kidding. Like there are a lot, health services, health policy people cannot really explain a global budget and how that works. Because it's not easy, right? It's very complicated. So I don't see that happening yet. Again, I hate to sound so pessimistic, but if you've been in the weeds or in the sausage making side of this, you know that we have a fair ways to go before we get to that, simplified system.
In the back here.
Hi, Molly McGarrick again, Deputy Cabinet Secretary at Delaware Health and Social Services. So probably an idea that's as unpopular as the Cadillac tax is to look at how not-for-profit status is determined for health systems, the fact that Medicare and Medicaid rates are allowed to be claimed as a loss without actually showing that the underlying cost structure that has led to that conclusion, in addition to being able to count building expenses, which add to fixed costs along with administrative costs that make it difficult for systems to say, well, I can't take value because seeing 10 less patients or 100 less patients does nothing to affect my bottom line. So we have to keep on this, fee for service. So I don't know. I mean, we don't really hear those things brought up in Washington, D.C., but it's just interested if there are other solutions like that out there that you all think should be more in the public conversation.
Well, Senator Grassley has been a champion of taking a harder look at those things, and he's the chairman now of the Finance Committee, and I recall in the last few months, some letters going out maybe or something to the effect of trying to reinvigorate some oversight to see, who's really properly categorized as not-for-profit and making sure that they follow the rules, maybe tightening the rules and so on. I'm all for that. I do think, however, if you step back from that and you ask the public, would you rather have, us move toward shareholder-owned, all of our hospitals being shareholder-owned because they all kind of look the same anyway, and what's the point? Are there really any distinctions to be made here and so on? I think the public is probably going to recoil from that. And that they'd rather have not-for-profit institutions than for-profit institutions. In some cases, they're not totally adverse to the for-profit hospital systems or insurer systems, but they also do like, slightly financially less interested parties trying to be a part of the system too. And so I wouldn't get rid of it at all. I would just try to police it a little bit better and make sure that they're acting in accordance with their tax status.
I would just add, I think we're about to see one really interesting experiment along those lines, and it's a new company called Civica RX, which was started by one of our members, Intermountain, SSM Health, and many others. And right now it's geared toward hospital drug shortages inpatient. They're talking and looking very seriously at moving into the retail space, and it's intended to operate as a public utility, a public good, not to make money. And I'm really interested to see if that can succeed and take hold and start to affect the market in some different ways.
We'll take one last one right here, and then we're going to wrap it up.
Alyssa Crawford from Mathematica. One of the things that I've been looking for throughout the day that I haven't heard as much as I hoped was the role of patient engagement in solutions either from the top down or the bottom up. Can you speak a little bit to how we really ask the tough questions internally within the healthcare system about what patient engagement means in the context of controlling health spending and rethink how we approach those decisions with a really patient-centered view?
Great question.
I'm going to say brilliant question. Kudos to you for asking it. I also think it's super difficult, especially in the United States with the culture that we have. Adaeze mentioned earlier, in the US, there is a firm belief that more is better when it comes to healthcare, and more expensive is even way better, right? I mean, that is just the instinct that Americans have, like, I'm going to look at the hospital. Ooh, let's go to that really expensive one because they're going to take the best care of me. So to say that this requires a massive education campaign doesn't even begin to, right? Like Health Affairs could probably dedicate, every issue for the next however many years to trying to explain and demonstrate and prove this over and over again to consumers. So, culture is something very, very powerful. I will say that where we tend to see little bright spots is when you can enlist clinicians in those conversations, because patients, for good reason, really do trust their doctors, their nurses, their pharmacists, for instance. And so trying to enlist and engage them on behalf of what makes sense. I'll point to out in Gunderson, many, many years ago, I wrote a story about the big push in that community to have end-of-life directives. And it was a phenomenal success. Just imagine if many more communities were doing that, how we might be able to move the dial just on end-of-life care. But it's hard.
I think it's a great question. I mean, I'll reiterate a couple of points. One of the hard-earned lessons that I carry around with me is, as a health policy person, as a leader of an organization, the importance of winning the hearts and minds. we live in data. We are often throwing statistics at folks. We all took statistics. We're all good at it. That's why we're here.
Not me.
Okay, so some of us are good at statistics. But I don't think that that often resonates with people, again, when they are most vulnerable. And I think that we undervalue the importance of that when we're in healthcare and healthcare policy. I think in the morning, just going back to Reed's opening, we're all relatively comfortable, and we think that the rest of America lives like this. But then a third of the country is teetering on the edge of bankruptcy or something like that due to a major health expense. And how is that voice, those voices, how are those voices represented, right, in this conversation? I can't say enough how important it is to get the clinician, the physician, in the middle of Iowa. That's my home state, and in the Midwest and some of the other parts of the country, to help people get to a place, to help themselves as clinicians get to a place where I'm not just going to throw everything at you because we have it, but quite frankly, we need to get to the place where we're talking about making you comfortable, asking you the hard questions about what you really value. How do you want to live your life as opposed to how do you want to die in a system? And I don't know that we do that enough. And speaking of, one of the questions we discussed when preparing is, how are we allocating our resources as is within the healthcare system? And can we kick the tires again a little bit to check whether we're doing it correctly? I would argue that we're not at all, as someone who understands a lot about aging, palliative care, long-term care, et cetera. And I think, I don't know if Patrick is still here, but they talked about primary care and going up from 8% of total expenditures to 10%. I think that's great, but my guess is the countries that do this well are spending much more than 10% on primary care as a total percentage. And should we think about perhaps increasing that number as a system over a short amount of time to really get control over costs?
Great. Okay, it's been a terrific, far-reaching conversation. I'd ask you to join me in thanking our panelists. So I'm going to take literally 2 minutes if you all could just stick with me. Literally, that's all I need. I want to say thank you all for being with us today. When I think back to Bobby's charge for the morning and the questions we hope to answer, I don't know, we'll have to talk about that. I'm not sure we figured out how much to spend, and I'm not sure we figured out who should decide, and I'm not sure if we figured out whether it should be bottom up or top down, but I think we figured out that in some respect the answer is it's all of the above on all of these. That no one is immune from participation in either the problem or the solution, and that as your 50-50 votes showed us, there's merit to both coming from the top and looking at it from the bottom, and that neither one alone is going to get us there. And as our lunchtime speaker showed us, that you need data whichever approach you're taking. So I won't try to summarize the day. I will say that I think we've had a rich conversation, and I do think we talked a lot more about action. There's certainly theory and concept, but there's a lot of action going on. So with thanks again to our partners at the National Pharmaceutical Council, our supporters at the Alliance of Community Health Plans, the American Cancer Society, Blue Cross Blue Shield Association, and the Council for Affordable Health Coverage, really appreciate your attention and interest. We are not going away on this topic. Health Affairs has been publishing on it since issue 1, volume 1, and we continue to publish both in the journal and the blog. We'll continue to hold events like this. Thank you again for joining us for the discussion today.
Thank you so much.
That's great. Thanks.